I'm in search of conversation guests. If you are interested or know someone that might be interested, please contact me directly. Thank you. Dr. Dazley, it's so good to have you on the show. Thank you for giving me this opportunity. So you're a doctor in, is it infectious diseases or actually give me your title, I guess.
Yeah, so I trained for 3 years in internal medicine. So that just means doctor for adults. Allopathic medicine, so there's no muscle manipulation, no osteopathic medicine there. And then after the 3 years of allopathic medicine, then I did a fellowship in infectious disease. And so that is usually a 2-year span where we study all of the antibiotics specifically and try to become experts of those. And then we also study HIV, hepatitis C, all the other viruses, funguses, molds. There's a little bit of transplant infectious disease where if somebody goes and gets a transplant, like whether it be a stem cell transplant or if they get a solid organ transplant, there's a lot of infections that could ensue because of the preparation for that and making sure that the transplant sticks. So those things are the things that we studied for 2 years, and then I did an advanced HIV extra year on that just because I like the research, and that's a big part of both the residency and the fellowship, especially the fellowship. So I think that's where, yeah, pretty much where I did all of my studies in the East Coast. And so it was in New Jersey, a little bit of New York, went to a lot of conferences in New York, published some papers over there as well, and then just collaborated with a lot of other specialties in all those efforts together, along with the conferences, et cetera. And then about 6 years ago, we moved from the East Coast to Las Vegas, and that's where we've been ever since at the VA.
What was I'm very noobish, or I don't know much about the medical field. So when you say, I mean, and publishing papers, I'm assuming that's a very scientific. So that's fields in chemistry, all sorts of sciences. But what's your experience with publishing papers? What was involved, and what did you publish about?
Yeah, so that started as an undergraduate, where I was an undergraduate working in the field of biology, working on a biology major. And I was actually working in a lab where we had small alligators. And so we did a lot of digestive studies on alligators. And we worked on publishing papers on digestion of these alligator models as an extinct or living model of dinosaurs. So it's kind of like looking to understand that aspect of different land animals and water animals a little bit better. And so in the process of that, we did have a gastroenterologist, somebody who studies the intestines, and the stomach and all that of the human, that collaborated with us. And they wanted to know something that hasn't been done before, and that was to look at the anatomy of the esophagus and the stomach and the intestines in the alligator. And so that was one study we did together, and we actually used some of the equipment they use in the gastroenterology field in order to do that. And in that field, they use pressure transducers to look at different levels of pressure going down into the esophagus and in the stomach. And they use that a lot on humans to see if the anatomy is still working properly. And if you see some weakness there, you may not have some of that pressure there. And so we were actually able to get some good measurements of the esophagus, the stomach, et cetera. And that was really interesting because not only did we get a good idea of the anatomy there, just looking at it physically in an extinct model, we were also able to get some of those pressure readings and get an idea for some of the disease that humans have. And that would be like gastroesophageal reflux disease. And that's where some people get a lot of burning in their chest that it's not related to the heart in this case, but it's related to the acid that's rising up into the esophagus from the stomach. And so if there's like a sphincter or like a gate that opens the lower esophagus down to the stomach, and if it opens and just doesn't have the ability to close, then that acid could just go up at any time. And so we were able to look at measurements in the alligator to see if they have the same kind of sphincter, and they do, but since they're always laying down, then you get a different read. Their sphincter is actually stronger, because if they're laying down all the time, down on their stomach because they're predators, then that would have to be tightly closed so that it doesn't open as they're laying down all the time. We're sitting upright, and yet the acid is still going up. So ours can sometimes get really weak, and that's because of our westernized diet most of the time. Mints as well as chocolate can actually open that sphincter so that people get more of that GERD, that gastroesophageal reflux disease. So we were able to kind of identify some of the things and publish that in a journal of experimental biology. And this was, wow, I kind of date myself, but it was several years ago. But it was a nice way to start out, and it was really exciting to get in the field with that being my first publication. And then as a medical student, we worked on some other case reports. And this is where you just take one patient and you kind of look at the experience, maybe like on a hospital course. So they're in the hospital for a certain reason, and you see something unique with their presentation, like some sort of disease that you hadn't seen, at least at that angle before. And then at that point, you're able to publish a research project based on exactly what you did with that patient and what were the successes, what did you do different, how did you follow the standard of care, which is kind of like the ideal way of treating based on the guidelines that we have today. And so we were able to do a couple of those studies as a student. And then after being a student as a medical resident, then I published some other papers along with some other medical residents as well as medical attendings. And that was exciting just because they were in some of the fields that I liked, which was gastroenterology as well as infectious disease. And I did a couple that were related to hepatitis C, and some, you can do a test on the liver instead of having to do a biopsy, which is a big needle that they stick right in the liver. And that's something you want to try to avoid because you can cause internal bleeding. And so now we do something that's kind of like an ultrasound. It's a glorified ultrasound, but they call it a fiber scan. And they just look at the density of the liver instead. And so it's a pretty good test. You can still stage liver disease based on if there's no scarring on the liver. And you can go all the way to cirrhosis, which is really where your liver looks like a raisin. It's just all horribly just kind of like scarred up, and it's not working anymore. Its functional unit is destroyed. And that's sometimes where you need a transplant. So you can stage each of those levels of that liver disease on this fiber scan. So we did some studies looking at that compared to some other modalities of trying to determine how bad somebody's liver disease is. So that was one of the publications. So there was that was like sort of like a retrospective study. And that's kind of looking back on what had occurred in the past and trying to determine what went right, what went wrong, and how does one test or one modality compare to the fiber scan. And so that was really kind of an easier test to do, or easier way of doing a study, because if you do prospective, you're looking forward into the future and trying to set up everything ideally the way you want. And it takes longer, but it is actually you get better results with the prospective. So if you put in more effort, more work, you're actually going to get better results in the end. And it's going to be higher powered and be more contributive to those that are looking at those studies. And then we did some vaccine studies looking at different HIV patients and their levels of immune status, to see if they have weaker immune systems. Should we give them a double dose of the hepatitis A vaccine, kind of like what we do with the flu vaccine? So the flu vaccine with older patients that have theoretically weaker immune systems, you want to maybe use a double dose of the flu vaccine, and that actually shows better results to keep them protected, because overall the flu vaccine is not like the COVID vaccine. The flu vaccine is only 40 to 60% efficient in people. And so you have like up to 60% of individuals who actually could get very severe disease and complications because of flu, even if they had the flu vaccine. And so that's not so good. So if you give an older person a double dose of the flu vaccine, then you're going to have higher chances of them having more protection. So we kind of like use that same model for the hepatitis A vaccine, thinking maybe that would be the same with somebody who's weakened with their immune system because of HIV or AIDS, which is where their immune system is probably at its worst. And we didn't find any correlation there. We did both a study looking into the past called retrospective, and we did a study looking into the future. And again, no correlation with either of those. So that was really interesting because that is a virus, kind of like the flu virus, but it is a very different kind of virus. And we don't see a lot of hepatitis A here in America. It's usually in other endemic places of the world. Or if you do see it here in America, you may see it with the homeless population, because there is some problem with that amongst the homeless in California. And there's a little pocket of that here in the Las Vegas area as well that we're watching closely. And so those were some of the studies that we did. I think there were probably 9 or so that we did that are in PubMed, if anybody's interested to look at some of those studies we've done. I think they're fascinating, just being able to be involved in those. There's other studies that we're still working on now through the VA. There's some difference of the way the VA, the Veterans Affairs, will do their studies. Everything has to be done through national. And sometimes it can be challenging to get all of the approvals and get also the assistance we need to make sure that some of these computer systems that they want us to use will be compatible and will work properly. So it's like we have to hire people in order to finish those studies. So it's still kind of a work in progress, but at the same time, the pandemic's been going on, so that's kept us pretty busy, to say it lightly. And so that's kind of had to be on the back burner for a little while. And so now that things seem to be calming down a little bit, at least for the moment, we're able to maybe pick that up again and hire some people and assist with those studies. I think it's just research is so interesting, intriguing, but also important for us, because as I look at other people's papers, I need to be able to also understand them and not just take them as gospel, but be able to skeptically look at them and criticize constructively whether it is a good study or a bad study, or maybe it's something that we need some more studies to collect along with that, so we have more evidence that what they're saying is true or could be true, or at least will give us a springboard for better studies in the future. So there's a lot in there as far as studies, and we just continue to learn more and more about how to improve those studies that we're doing.
Is there something for a common person to better understand that quickly? When you say the studies, say this COVID information is just coming by so quick, it feels like there's new information. I mean, it would surprise me even how long ago was it? I think 2 months ago when I interviewed a software engineer, and his daughter, their whole family had COVID. His daughter lost taste, and it was still 5 months after it, and she still hasn't recovered her taste. And at that time, when I was searching like Google and YouTube, I didn't really see a lot of information on that. Sorry, I just went on a total tangent on my first question was, how do common people get good information and or know what's good or bad information? Let's go with that one. Sorry, I went on a tangent.
No problem.
What would you suggest for the common person to try to stay up to date and get good information?
I think a good place to start are just certain news media that are more reliable. I think if you start with something like the New York Times, that's pretty reliable for the most part. If you look at it, there aren't any crazy, journalists that are going to give you some really opinionated views. Their views are pretty objective overall. And I think they also put an inlay also in there of the original article that the information was based upon. And I think they really try to make it so it's simple for the layperson to understand. And they'll actually highlight some really important points about what's going on with the pandemic with specific nuances of what we're doing now. So that could be treatments, it could be testing, it could be vaccination, it could be even what we've learned along the way, and the CDC guidelines, and that I think because I'm looking at these every single day because I'm trying to give information to the leadership of our hospital. So for me, it's been just amazing to become informed looking at that. And I think overall, they're not so biased like a lot of times you would think they are based on the politics. I think overall it's pretty objective for any way you look at it, because I know there is definitely a lot of way that everything's politicized a little bit too much overall. So I think if we understand we're just trying to just protect our population. And so giving us this informative information that's objective is just so so important, and making it transparent for all to understand. And I think they do a pretty good job of making it so that the masses can understand, because these studies that I'm talking about are scientific works that are in scientific journals. Like one of them that has a really high rating, what they call the impact factor is extremely high, is the New England Journal of Medicine. A lot of people have heard of that one. Maybe the Lancet is another one that a lot of people have heard of. And these are, yes, they're for the masses. Sometimes they're more for those that are a little bit more scientifically skewed. And they have a simple introduction. They have the body, which is going to discuss how they did the study, the methods of their madness. And then they kind of go through a little bit of the discussion, and then finally the conclusion. And so that they make it so it's simple enough that you can kind of understand what they're trying to say. But I like looking at the New York Times because that expresses it in layman's terms enough so that somebody who maybe doesn't have that sort of career can really understand the nitty gritty and all the details of it. There's not only New York Times, but you can look at the BBC is another great one that I like because it's subjective again. And you not only are looking at America with that one, but you're looking at the world, which is really even better, because New York Times oftentimes will just focus on here in America. And that's like a lot of the media that we see here in America is only going to give you information about here. And I like to see what's going on around the world, because that's going to give us a lot more information. Like, for instance, with the pandemic, who was the first one that had vaccinated most of their public? That was Israel. And to get details about how the Pfizer vaccine was working for them was amazing, to see what kind of improvement, like the efficacy, the safety. And if you're looking for signals of certain disease that's coming out because of the vaccine itself, it's there. And so they have also published their own scientific data based on what their experience is with COVID that was very helpful for the rest of the scientific community and the world. Some of your local journals or even just newspapers that are online may be helpful. In the Las Vegas area, we have the Las Vegas Review Journal. It's just you have to be careful because some of those articles are going to be a little bit biased. But overall, they have pretty good information, like especially if you want to know, hey, are the numbers improving here as far as the COVID patients or not? They'll give you a 7-day average of who is still having disease, et cetera. And so that for the masses, I think, is fantastic, because a lot of the masses, a lot of people that I talk about every day, whether it's patients or other individuals that I encounter in the community, there's a lot that are just not in our bubble of, they don't see the kind of hospitalizations that are out there. They don't see the death. And so a lot of them are thinking, oh, well, this is all a hoax, or this, is really exaggerated, when in reality, I see the deaths every day. I mean, we had 4 or 5 deaths in 1 week within a 48-hour period, and it was painful to see that. And some of it is a lot of out of our control, but we're seeing a lot. And that's even in a small hospital setting where we only have like 100 beds in the whole hospital. And, some of our neighboring hospitals have 1,000 beds. So you can imagine you're seeing a lot more deaths than we are, but we're in our own little world. So we're only going to see a certain number. So just looking at the subjective data in some of those news feeds will definitely give us information. They should be trustworthy. There should be certain ones that are going to give us more objective information. It's a little bit harder to look at maybe Fox News, et cetera, and believe everything you're going to see. It's going to be a little bit more biased, and you can expect that to be the case. But overall, I think that's what we're trying to say by the scientific literature. Everything we try to do is science-based and also, compassion-based. Because I think a lot of people think, oh, well, you're just worried about the science and that's all you're worried about. But I think there's also the experience in there as well, like the difference between the word efficacy and effectiveness. What does efficacy really mean? It means what is the how good is this vaccine, for instance, when you're looking at the data, just the objective data. And then what is the how effective or how good does it work when you look at the real world, and that's effectiveness. So you get those two different worlds that I think are important when we're trying to understand as scientific individuals or as just people or clinicians. We have to sort of have a good balance between the two, because there is some tension between those two as well, sort of a tug of war between the two, if you will. But I think it's important when we want to take the pulse of our patients or those around us and understand the public view, but then also be able to be objective in our approach. And that's where that scientific background comes in as well.
Yeah, I'm a software engineer, and this will be an interesting. It's a long story, but I'll connect it with medical software. It's gotten massive in the last 20 years, 30 years. I've been a programmer since 2000, 2003, and I've been working in IT since 2000. So the world of IT and programming is so deep that even for me as a software engineer, when I go and look for information about a specific software, say I'm looking at using TikTok's not a really great example, but TikTok, there was a known hacker that no, I'm sorry, he wasn't a hacker. He was a known programmer that was looking at information about TikTok, and he was doing network analysis on the data coming from his phone when he had TikTok installed and when TikTok wasn't installed. And he noticed something, there was a lot of data going out when it shouldn't have. So he went deep into trying to figure out what data was going out. So as a software engineer, some of it I'm able to understand it better. So when I think about that, when he published his data, we have to be a little bit potentially, we can't trust everything we see, but for me as a software engineer, I'm able to look at his results and kind of understand a lot more than the common person. So when I look at medical publishings, I try to look at some of the vaccine data, the results that they have and the testing that they do, and I see statistics and things that's hard for me to understand. So I don't really have exactly a point to make. It's just that it's so tough, I think, for the common person to understand medical, computers. I mean, they're everything. Maybe we as humans are getting to a place in time where we're getting so much research in everything. I mean, the last talk I had was with a med tech, a clinical laboratory technician, and even talking with him about COVID, vaccines and stuff. Then you said something about I forget. You said the 60% of the flu vaccine may not work or something, and I'm like I just had a conversation with him about vaccines, and I'm just like, whoa, I didn't know that other 60% thing that you just mentioned. So it's just the world of information is just so deep. So I'm going all over on tangents. So what I do with software, I try to look all over the place, from New York Times, Reddit, Google News. If I could get onto GitHub, if I could find the programmers. So that, to me, I also try to do this with medical information. I try to find doctors that I watch enough of their YouTube videos if they happen to have a YouTube channel. And I don't know how many doctors are doing that, but I found three that I really like. One is Michael Osterholm. I really like his information. There's another one, I don't remember his name. I have his YouTube channel subscribed and I watch it every time. He's doing a lot of COVID information. Gosh, I forget his name. But then So there's three doctors that I really like. Two of the doctors, surprisingly, I don't remember their names, but I do remember Dr. Michael Osterholm. Um, so I guess with the published data, New York Times, and then trying to get on YouTube, and it's a world of so much information to intake and know what's accurate. I don't think, like you're saying, I don't. Some things are politicized, but there's a lot of people that want to help. So it's a tough thing trying to sift through the right information.
Mhm.
So sorry about that.
No, that's great.
uh, um, Out of curiosity, you said you came from New Jersey. You spent the majority of your life in New Jersey.
Well, mainly it was just for our medical training. So we had spent some time in England, and I was just doing some pre-medical sciences in Cambridge, and got to know some of the professors over there, and ended up, spending some time in the Caribbean, and then from there to New Jersey. And New Jersey was mainly for the medical training, so medical school as well as the residency and fellowship. So roughly about 10 years was spent over there. So roughly, most of my son's childhood was there. So that's what he remembers mostly. But yeah, it was a great place to be. I was really in several different cities there. My main headquarters was the main hospital I was at, which was in Newark. And so that's a big hub there with just a fabulous place to learn medicine, because you're going to see just all walks of life. You're going to see a lot of indigent population there. And there's just a lot to learn with a lot of HIV there. So somebody who's more leaning towards studying infectious diseases or even pulmonary critical care, any of those things, they're going to learn a ton from just being in that city. And it's just such a quaint state as well. It's a fabulous state with a lot of people that have come from that place that have been great celebrities and great people. And then we spent some time in Elizabeth, which is predominantly Latino. So we love that place actually, because you get that demographic and you get to learn about how the body responds just because of their genetics to different things. So that was a fantastic place. There was a hospital that we were at called Trinitas, and so we were there. And then St. Michael's Medical Center was the one where we spent some time at. It was in Newark. And then we also spent some time in Patterson, and that's a big population of both a lot of Arabic individuals as well as Latino. They have a good mix of everything. It's a very inner city, fantastic, historic city where they have a big hospital called St. Joseph's and a thriving sort of referral center. And so a lot of our just big pathology we saw there at that hospital. And so I learned a ton just being right there in that population. And it was probably my favorite overall. And then I did do a little bit of transplant infectious disease down in Texas. So I spent about a month down there. I could have gone in Pennsylvania to do transplant, but I opted to go down there to MD Anderson, which is a huge cancer center. And so it's just like a city. You walk in and you're just like, wow, the place is so big. You have to use a car to get from one side of the hospital to the other. Honestly, they take you on a
Wow.
little shuttle from one side to the other. And it's just huge and fascinating. A lot of people from all walks of the world would go there. And then at the time I was there, actually, was the time when one of COVID's cousins became apparent in the world. It's called MERS, so Middle Eastern Respiratory Syndrome. And this is kind of to be likened to SARS, which is back in 2003, 2004. This one came several years after, but we were doing the same sort of workup as we would do on any other, sort of like a novel coronavirus, where we have to isolate the patient in a room and then follow a certain algorithm of different testing to do, et cetera, and then wait for the testing to come back from the CDC. And this particular virus was actually something that you could get from camels. So those that maybe lived in the Middle East. And so we got a lot of cancer patients that would come from the Middle East, and they would come there for their treatment. And because they came from that place where they might have had contact with camels, that's where we would do that workup. So it's kind of an interesting thing that we went through in preparation, of course, and that was my whole training was preparing for different things like a pandemic, because we have outbreaks all the time of different disease processes that happen to be infectious in nature. And there's probably 50 to 100 people that die every year in different regions around the world because of these disease processes. And so we continue to face that today, and we will continue to face that in the future. So the last pandemic we had was 1918, so it's been a long time since we've had one. Nobody's really had that in our lifetime. So now we're facing this one, but since our population continues to grow and we continue to see the impact of climate change, et cetera, we're going to continue seeing different populations uprooted to different areas and different disease processes, whether it be virus, bacteria, et cetera, more outbreaks and possibly another pandemic. Hopefully not in our lifetime, but we never know that. So we continue to watch and wait. But yeah, so 10 years in New Jersey was a fun time. I think overall I could have just stayed there forever, but my family wanted to move closer to the rest of their family. So we had to just adopt that philosophy: happy wife, happy life.
So you chose to come back to Las Vegas, or did you have to find an opportunity medically, or is that kind of easy to jump from, say, at that time, if you were in New Jersey, you were able to find something in Vegas pretty easily, or was there a transitional phase?
Yeah, it was a little both, but I think over there we were like, okay, so where are we going to come? It was a lot of meditation, a lot of thought, trying to consider what would be best for our family, what would be best for how we can contribute to others best, and kind of came to a nice compromise, a place where the weather is nice and where maybe I would have an opportunity to treat a lot of infectious disease. And definitely Las Vegas is a place where you get a lot of infectious disease. We're the syphilis capital of the United States. So there's plenty of sexually transmitted disease. And since that's right up my alley of things that I treat, then yeah. And so I went through a recruiter and found the VA while we were in New Jersey. And it was something where, I thought, I just had this gut feeling that this would be a good place to be. I kind of felt the same way when it came to St. Michael's. It was a gut feeling that I should start there, and it turned out to be a fantastic place to be, to learn and to grow and to sort of complete that chapter of life. And this was the same way. I just felt this was the right place for us to be. And so we moved here and have been working with the VA ever since. And it's just been fantastic so far. We've learned a lot, and definitely during the pandemic, it's been a growing process.
Was there a transition in knowledge from switching from, you said, internal medicine to infectious diseases? Was it an easy switch for you, or was it a big change?
Well, I think, when I was in internal medicine, I was already kind of gearing towards infectious disease. It was already an interest, and I would spend more time than I would in internal medicine or doing other things with those that I worked with, and, those that were maybe teaching faculty there, et cetera, and some of the fellows that worked there that were already in infectious disease. And, you do rotations in that area as well. So, yeah, it was definitely a transition, but I think overall it was hopefully a smooth transition, at least as I remember it. Definitely the hours were a little bit more because I would have to get there earlier to see patients. I would have a much greater load of patients because as a medical resident, there's a cap on the number of patients you can see, a cap on the number of hours you can see them. And there's a little less of that, a little more blurring when it comes to a fellowship when you're doing subspecialty training. And so we would see, 30, maybe more patients a day in infectious disease. So that was definitely a transition. And the hours, I would get there at 5 a.m. and not leave till 8 or 9 in the evening. So it might be worse for some disciplines. Maybe they work harder than that. But for us, that was challenging because it was, kind of like a continuous running the whole day sort of thing. So, and then the other transition was getting to know that field and just owning it really. And that field, the biggest thing is understanding the ins and outs of all the antibiotics. so that if anybody were to ask me a question about an antibiotic at 2 or 3 in the morning, it'd be like a knee-jerk reaction. It's just, here it is, that reflex, and I could tell them everything I know about it. So that was definitely a big transition. And the people I worked with there, probably different. There's definitely a cerebral group, and probably they're not so into procedures like they would be in gastroenterology or in cardiology or even in general internal medicine. It was more cerebral and what's happening in every system of the body. So that was a challenge, because certain fields, you're just going to focus on one system, like cardiology, they're just going to be focusing on the heart and the vessels. If you're dealing with gastroenterology, you have a few organs there that you're dealing with: the pancreas, the liver, the stomach, the intestines, etc. But it's kind of an isolated system. But with infectious disease, it goes across the board with all of the different systems, and you're kind of working as a support base for each of those specialties. So we have to work in collaboration with all of them and be that cerebral support base for them, and be the expert for the antibiotics and make sure that they're working properly, make sure we're not missing another thought process as far as the diagnosis. And just, it's a daily battle every day, sometimes 2 or 3 times a day, where we're following up and making sure that everybody is on the same page when it comes to disease processes.
So when I think about IT, it's a funny connection. When I've produced some code and it's out at a company at the company that I'm working at, and someone has an issue, a customer or an internal staff, they may come to me and they may be upset. They're like, "Hey, this is not working. The software is not doing what I want. I clicked on this, is not," and they got all upset. And they think that I should know everything. I'm the one that wrote the code. But when you're dealing with software, it's massive. It might be, I'm gonna guess, 200,000 lines of code, a database that's connected to this 200,000 lines of code, and these 200,000 lines of code has oh man, I can't the word. It has circular loops in its algorithm or its thought process. The way the code may refer to another piece of code, and that code may refer to the first piece of code, and it may do a circular loop to some degree. So troubleshooting that is, when I try to explain to people, when you got a problem, that's what I'm trying to figure out for you. It doesn't help by yelling at me. I'm going to do my best as best as I can, regardless whether you're yelling or not. Do you get that as a doctor? As in, do patients or staff members thinking that you should know everything in infectious diseases, antibiotics, or whatever their question may be regarding? Do you see that they get upset at you, or are people usually are they easier towards doctors by chance?
Yeah, I think it's sometimes they treat us very well, and sometimes it's just the opposite. It's probably similar to a lot of other disciplines as far as how people are being treated, how we're being treated in general. But I have noticed there's unfortunately the disparity of how they're going to treat a nurse versus us, because sometimes they'll lay into the nurse before we get there, and then with us they're all nice and stuff. And I just feel so bad, because that's not the way it should be. They should not be the ones to be vented on, because they're not the ones taking the liability. They're there as they have their role that's very specific, and they do it well, and they oftentimes spend a lot more time than we do, and oftentimes diagnose the patient better than we do, because they're there so long, and yet they're the ones that are bearing the brunt of the burden as far as how people are treating them. And then oftentimes, I'll just give you an example of one experience that we had, and this one happened about a year ago, about a year and a half ago, actually. And this is a gentleman that came to our emergency room, and he came in with an infected toe, because he has diabetes, and he's got a problem with his circulation, a problem with a possible infection there. And we look at it, and we have to have this collaborative effort, not only with ourselves, but in this case with the foot doctor and the internal medicine person, etc. And in this case, our objective was to get everybody on the same page, and then make sure that this wasn't just a dead toe where maybe the bone is just not going to be revivable by antibiotics alone. And so to help everybody understand that is a tough thing sometimes, and people sometimes are not happy with our plan. So we decided, okay, we're going to just have him go home, the patient, and then they can follow up with the foot doctor and they can give the treatment along with us, and we can provide the support that they need. But most likely he's going to need surgery to remove that bit of his bone. And that totally makes sense. And that's guideline based and standard of care. And the patient ended up bouncing right back to the emergency room not long after with the same issue. And he was hoping that he would, maybe talk to somebody different who had a different view and would put him on long-term antibiotics. And unfortunately, with something where there's no reversible infection of the skin or something around there, then perhaps that's not the right avenue to go, especially if he doesn't show signs that he has an acute infection now. And I didn't think that this would be the right decision just to give him antibiotics just to make everyone happy, when I could be causing the antibiotic in the future not to work anymore. And I could be making it so that perhaps he could have some other side effects because of the antibiotics also. And so I think, thinking about the Hippocratic Oath, first of all, that we take as a physician, first, no harm. We're trying to be a benefit to them more than anything. So unfortunately, he wasn't happy. He wanted to see somebody else, and that's fine. And so we had him go see another provider, and then he canceled the appointment anyway. And later he ended up coming back upset. And so that was after he already had his toe amputated. And then he ended up having more toes amputated because the problem kind of spiraled out of control. And so I think this is one example of an individual where perhaps, it's just tough because you want to be at the same level as them. You want to show compassion and be caring and also have a good scientific approach, so that we have some good objective data, so we understand where we're at and how we're going to treat. But we didn't have the collaboration we desired, and we wouldn't be able to just treat them all alone. And that's the thing about medicine today, is it's so highly specialized that we can't all just treat all on our own. So we have to work with a lot of people, and we have to be really diplomatic with everybody, including the patient. And today's age, our patients are much more educated and understand what it is that's going on with them. We have patients that will come in with all of their records and just amazing graphical form, and they made the graphs themselves. And it's just amazing to see this. And these are not always people that are, that have a doctorate or something like that. They just are very involved in their own care. And that's today's age. And I love it. I'm so happy we're not in the paternalistic era where we're just making all the decisions for everybody. I don't want it that way. I would prefer them to be involved in the decision process. That one thing that I learned as a trainee or even as a medical student was it is so important to just take the time to listen to the patient, to listen to their history, rather than just saying in 2 seconds, I've got the answer. This is a diagnosis and we're done. Goodbye. I just don't think that's the right way to do things. And I'm not just trying to make myself look better. It's just, it doesn't work as well as if you just sit and listen to the patient from the start to the finish. And it's not just giving them time at the beginning to tell you what they think it is and give you all the details. It's listening to when they're telling you the subjective data of what's going on, to right at the end when they're saying, well, what if we try this? And then I start looking through or thinking about the literature I've read, thinking about the standard of care and the guidelines, thinking, hey, maybe that will work. And a lot of times I feel like maybe they were inspired at some level, and it worked out great if I just listened to them, And so I think that at some level is wonderful, and our society is changing with that. And I think it's going to become more and more so. I don't think you have so many that are just looking at Dr. Google, which is not going to help anybody. I think you have some that are really looking subjectively at, not necessarily looking at the guidelines, but they're finding ways of getting good, reliable information about their own care. And that is helpful. And they're really listening, and they're taking the information in. They're compiling their records in a way that we can then get the data much smoother and have a much more seamless way to treat them. I think that's so helpful. And so I think that's where sometimes things are challenging at times, and I do run into those scenarios, but it's like maybe 1% or less of the overall experience that we have. And I think a lot of it has to do with our own attitude and how we approach the scenario also, and just try to give as much care as we can into it and give them the time so that they can understand that we're, not just going to give them a diagnosis and say goodbye, here's your treatment, and really take the time to make sure that they understand. It's just hard, because today, with the kind of volume most providers have, that gets so challenging. There's such a shortage of providers to be able to give them the time of day that they need to really explain and be comfortable with who you are and trust you, because sometimes they're trusting you with their lives. And that's a challenge. And to know sometimes that even when they're trusting me with their life, and knowing that, like with COVID, where we don't really have sometimes control over it, we give them the best that we can as far as care, and yet we still have that gut feeling that nothing's going to work, that they're still going to expire, they're still going to die, and that's unfortunate. And I don't ever want to be pessimistic, and I always want to reassure the patient, even if the odds are not in their favor. And so that's hard too. But I think overall the experience has been overall pretty positive, both for the staff members and for myself. It's just, a certain percentage are going to come in and just want to vent. But I have had those experiences, like with another person that I remember I treated once, where they came to our clinic just completely closed off, just angry, didn't want to talk to anybody. And the nurse said, "Oh, good luck with this one. This was going to be a fun one," because they presented the case to me, and then I went to go see the patient. We talked and we talked some more. And by the end of the conversation, thankfully, they were just appreciative and happy and ready to come back and get more treatment. But it's really tough, because sometimes there's a shell that we have to break through initially. And there's a challenge because of whatever experience they've had. And sometimes that's the challenge, is just trying to learn how to have better people skills sometimes to do that. I know, because I've worked in different careers. I've been a missionary before, and just worked in different venues where it's definitely helped me to try to be better at those things, so that overall I can be better at, getting at their level and just, being there for them where they are, no matter where that is. They could be way at higher levels than I am, for sure, because I've had some providers that have come into me for care for hepatitis B or something that they've had since birth or since their adulthood. And so that's been a wonderful challenge too, to know that they're probably better providers than me, I'm sure, but then to be able to provide the care that they deserve as well. And many of those are ex-military. They served in the military for many, many years. So I just have such a great admiration for them. And then they're veterans, and then they've been providers for so long, much longer than me. And so that's always a good learning experience, where I can say, well, what can I learn from them while we're learning and growing together? And I'm trying to also assist them with this disease process.
On that part where you said about only 1% of patients that come in that really know their condition, am I phrasing that correctly, where they actually give you enough information for you to understand their situation?
I think the 1% is the experience that I have that's more challenging, where maybe no matter what I do, like that individual that I was sharing the experience with, I called him after the experience where I found out that he wasn't happy with his care by me. And then I also sent him a letter, just kind of like just pouring out my heart, just kind of just sharing with him, well, I'm so sorry, I didn't want it to be this way. Please do get a second opinion. I just want the best care for you. It's not about me at all, and et cetera, et cetera. And yet still, he wouldn't give me the time of day to listen. That's probably just 1% or maybe less of the population. I was just trying to say how optimistic things really are. It's just some of those few experiences you have really stand out, and it really just, it's heartbreaking sometimes, really.
Yeah, I bet. For the people that you mentioned, the people that seem to know their condition well, I think you mentioned that, where they're able to accurately describe their condition to you and give you information. What percentage of patients are like that? 5%, 20%?
Yeah, I think that overall it seems like maybe 50 to 60, depending on where you are. I mean, I'm in a sort of a skewed population because I'm with the veteran population where, of course, since they were, 18 or whenever they entered the military, they are programmed or they learn how to really be disciplined and to really, I guess, to refine each aspect of their lives to form good habits for the future. And so, in a lot of ways, I think that carries out in the way that they are. If you're in the general population, you may have individuals who just have a variety of different backgrounds. You may have a lot who maybe just have, really um, just excellent backgrounds of high education status, or maybe they just have a lot of understanding or knowledge of that. But my experience at this point is with them for the last 6 or so years. And so I guess that's the thing that I recall the most is how that is. So I would say probably right now with the population I have is probably 60% of them are that way or more perhaps. But those are the ones that come to my clinics. So again, I don't have the general population perhaps that come to see me so much of the veterans, but sort of a skewed population that are HIV, hepatitis B, hepatitis C, or have other issues that maybe they were just in the hospital and then they came to see me after their hospitalization. And this may be a really complex case. For the most part, I'll get a veteran and their spouse is the one that's giving me a lot of the data, and they're sharing with me a lot of the background and just all the things that they can retain in their memory or by record, etc. But then of course some of them, they know all that stuff on their own as well. One of them I was just amazed by today, where he had a really complex hospitalization where there was twice where they had to revive him where he almost died. And usually when that occurs, these individuals, their IQ goes down because they lose brain cells, and their mortality, meaning that their chances of death, go way up. And this guy, wow, it's amazing. He had mechanical ventilation for several weeks, and he was in the hospital since October until February, and that's a long time. And now he's in with me in the clinic, and we're just kind of following up and everything. And he remembers everything perfectly and has everything on his phone. And he's an older gentleman, but yeah, he has everything very well organized. And I was just amazed. And so that was great.
The topic of that, where people try to learn their issue, or what physical issue that they have, or problem, bones, muscles, whatever. It's a bit personal to me because when I about 6 years ago, gosh, 5 or 6 years ago, I was in a car accident. I actually don't remember the exact amount of years. Um, Fractured my, if I'm saying the bone correctly, fractured my talus bone, talus bone in the ankle, and I have 3 screws in it now. And because under all the morphine and the OxyContin, I wasn't in the state of mind to be able to do all the research and try to figure out what were my best options. Um, to make the story a bit short, it was 6 months later where I asked about stem cell surgery, and a doctor she was super ecstatic that I asked about it. And I'm like thinking, wait, I've seen you for how many months now and you never even mentioned it? Like, why did I have to bring it up before you're ecstatic about it? Now, I'm jumping around, but I'll connect it to, I just bought a new big TV monitor for my computer. I spent 20 hours over 6 weeks researching 4K, 2160p, how many pixels per square inch, HDMI display port, like all these. I spent 20 hours over 6 weeks researching. But when I had my accident, why didn't I spend time researching about my foot, what I could do, what I should do? When should I be weight bearing? Now, granted, the weight bearing thing, I think the doctor should have told me. I think something got lost in all the appointments, and the doctor didn't tell me to get weight bearing within 6 weeks. And I waited a few months before I tried to get weight bearing. So that was a bad situation, I think, for the bone, because the lack of oxygen in that bone, I think probably that's not good to be just sitting around for several months. So I wish, thinking back, I wish I would have been of this of sound mind to be able to research about it. Or I wish I would have known to maybe ask a friend, somebody like a super close friend, someone that I could give executive orders, executive powers to. I know that this, you're nodding your head. I think you understand where I'm getting at. I don't know if there's a term or even a way to facilitate that. Meaning, if I trust my cousin, who me and him, we're super close. We've lived together for probably 17 years in the last 19 years we've lived together. So we're super close. I mean, we have a lot of financial ties together, and there's plenty of times where he could have ran with my money, I could have ran with his money, but we just aren't like that. Now, I wish I would have told him ahead of time, hey, if I were to get in a car accident, I'm heavily doped up on morphine and Oxycontin, please make some executive calls for me. Please help me out. I didn't I didn't think about it, and I don't think anybody thinks about it. I don't think anybody knows to do that. I don't know. So I don't really have a point for that. Do you see that patients should think about that before before accidents, or how should they think about
Yeah,
that?
I think, I mean, I know that, like in your case, you're very young, and so a lot of times we don't think about, oh yeah, I'm gonna need to like um, prepare an advance directive, which is kind of like what will happen at the point where I'm not able to make those decisions on my own anymore. And then also plan somebody to be what's called a power of power of attorney. And these are the individuals, like you're explaining very well, that would be the ones who would make all those decisions for you in the event that something that like that would occur. And I think it's a very good decision to do at any time, right now. The sooner the better. And honestly, there have been lots of scenarios where in the emergency room we see individuals who their life is completely altered because of either an accident, like you're explaining, or just something that happens spontaneously, whether it be genetic or whatever that we just never saw before. Like one guy that came into the emergency room and he was not that old, he was pretty young, and when I saw him, he was completely unconscious, unable to do anything at that point. And we found that he just had a spontaneous massive bleed in his head. And he was basically a vegetable from then on. And so it's like, okay, well, at some point, you're going to need to pull the plug. And we need to know when to do that beforehand, because if we can't get a hold of family, or family's not involved, or they don't want to make that decision, then that advance directive is going to be very helpful to be sure they receive exactly what they want the patient, because we don't necessarily want to do what the family wants. We wanted to know what the patient would have wanted if they were able to speak to us and let us know. But if they're not able to, then we're just completely out of luck, and that makes it really tough, because sometimes you're giving a lot of care that they don't necessarily want. Maybe they don't want such aggressive of care. Or alternatively, you don't want any lazy doctors or providers in general just to kind of say, oh, well, it doesn't matter, and then not do anything when they really wanted aggressive care and they really valued their life. And so that's the other side of the coin that I think is important, especially if somebody's younger. They may have a lot of years of life still to live. And so you want to be able to give them the kind of care that's tailored to what they want. So yeah, the advance directive as well as power of attorney becomes so important in those cases. And then sometimes we have to decide how much capacity they have at that point. So sometimes mental health advisors or helpful psychiatrists can be involved if they're kind of coherent, kind of lucid, but you're not certain about their capacity. So that would be then the psychiatrist's job to then intervene also, to
Mm.
determine that with more clarity, more objectively. And then from there, we can really have an idea of what next to do for that patient that's going to be helpful for them, so that we can create the spectrum of care that's best for them. And again, I think with more and more individuals being so in tune with their own care, more people are opting to prepare these things and understand. And I think that's where the do not resuscitate, do not intubate comes into play also, where sometimes, whether it be religious or whether it be whatever the case may be, some families will just want everything done for their family, even if there's just no possibility at all. And I've had many experiences with that, and I totally respect them. I am a religious person too, and so I will get at their level when it comes to that and talk to them and say, we also do believe that God should be in this conversation as well. And as soon as you enter that into science, wow, that just opens up a completely different door for certain individuals that are more in tune with that. If religion is not the answer, then of course we need to be sincere with whatever our conversations that we have with them would be. But I just had so many experiences with that where sometimes you can just build on relationships of trust with them. And then at that point, we can understand what exactly is it that the patient would want. And oftentimes the decision maker can have a conversation with the rest of the family, especially those that were closest to that individual. And then the real desire of that patient sometimes will come out. And that is so helpful for us because then we can, be able to give them exactly what it is that they would want. And I think overall we just feel much more accomplished and at peace with that, because then you can, with such a knowledgeable patient base, that really helps. Because I think that's one thing about medicine today is that medicine is really defensive, at least in America. And what that means is a big part of our training is all about protecting providers in general from lawsuits. And so what are we going to do in defensive medicine to prevent those? And I think it's unfortunately the wrong way to look at things, but it's unfortunate that in our society, there are a lot of lawsuits that are generated each day. And so there's definitely an increase in cost of medicine because of that today. And so if we don't know what the patient wanted, especially, then we may end up incurring a higher cost for the patient for no reason as well, or vice versa. Maybe we're not doing enough, and that becomes a problem as well for defensive medicine as well. And I think overall, we should be more into diagnosing properly without having to use all these other special means. But we do have a lot of technology in medicine today that is amazing, with different kinds of things like 3D MRIs and things that are just like very interactive, very intuitive as well when it comes to technology, and highly effective. You get some really highly specific tests that go along with that just go beyond my scope of practice and beyond my pay grade for sure as well.
That time where a patient is in a coma or about to die or just barely hanging on by a limb, and you're saying if the family member has to make a decision, I like that you're saying what would the patient want. I think that sounds like that's a fantastic phrase. I've told my wife and my cousin, I said, if I'm in a coma for an extended amount of time, if you can, ask the doctor if they could give me a bunch of oxygen and let me die that way. I hear from a BBC documentary, if you pump a lot of oxygen, pure oxygen to somebody, after an amount of time, you go through you could have a euphoric death, supposedly. I don't. That's the documentary what BBC was doing. So I told my wife and my cousin, if I'm in a coma, if something were to catastrophically happen, and I'm in a coma for a very long time, see if you could ask that option for me. Does that sound completely stupid to you, or?
No, I think it would make sense. I mean, they'd probably want to add a few other things to help along the process so that you would be able to pass without too much suffering and dignity, etc. And hospice is a great option. I think a lot of people think, oh, that's just a death sentence. It is something that we would start in a patient that perhaps has a shorter span of life, but hospice sometimes will expand somebody's life because they're getting greater quality of care. They're going to have, providers and staff there with them, whether it be in the hospital setting or at home, that can really give them the kind of focus they need. And they're not necessarily going to treat every single little thing that's going to cause more pain to that patient, but they're going to focus on the comfort of that patient. So not only is it going to be those high doses of oxygen, but perhaps a dosing that would be appropriate of morphine to help them to be more comfortable during the process and to ease their breathing also, not necessarily to stop their breathing, but to ease it so that they're more comfortable and they don't make those loud and sort of like sounds that are agitating to the family. The family's like, why are they breathing like that? That just sounds so horrible.
Yeah.
And so they have different ways of eliminating that or improving it so that the patient, again, has a more quality driven end of life experience. And the step before this is palliative care, and that's even more focused on the quality of care for these individuals and their comfort before we have to take the next step of hospice. And so I think both options are just fantastic. And whenever there's a patient or somebody who doesn't like the idea of hospice, because I know it's a lot of times they're thinking, okay, that's the end for me, but not necessarily, because I think a lot of times, like I say, we've really had a longer lifespan, and these patients want to live. They have more desire, more will to live when they're in palliative care. And so it's just fantastic. And so they give all those other details for the patient where they can be at home or in certain circumstances they're in the hospital. But the ones at home, I mean, that's fantastic because you have the family all around them, especially in this age of COVID, where a lot of hospitals don't allow you to have your family member in the hospital with you right now. And that's been the scariest time for these patients and the saddest as well, because they've had to die alone and without those that they really care about. Sometimes it's just a staff member they just met, and that's the last person they see when they're taking their last breath. And I think that's just so sad, and it breaks my heart. And so we're just excited about getting back to some normalcy so these types of experiences can also be addressed with more care. And I think at this point we've learned a lot. And so we can focus on these things with new insight and new excitement overall.
What do you think some are the most important things that you've been seeing currently with COVID, or things that you've been interacting with recently?
Yeah, I think at this point it's really just one thing I think is we've been able to refine at this point what COVID has been and what does it do to people. And so we've been able to break it down into different phases of disease process. And the first one is, as soon as that patient comes in, we have to really just jump on them as far as treatment, because they're already in the first phase, which is where the virus is really replicating quickly in their body. And we want to catch this before they get into the inflammatory phase. And the inflammatory phase is where the immune system is starting to just look around and saying, what is going on? I've never seen this before. I have no idea what to do here. So they kind of scramble and they cause like a storm because of their scrambling effort trying to help. And they cause more damage than what is worth, unfortunately. And so that's what we're seeing is they get to this replication phase and we immediately start treatments to try to see if we can kind of control things before we get into this inflammatory phase, because that's where things kind of spiral out of control. That's where a lot of times they end up on mechanical ventilation, and where maybe they have kidney damage and that worsens. Maybe they even have a stroke or whatever may happen during that phase could occur and things get worse, and it's hard to reverse it at that point. And it's where we have to give things to really weaken their immune system. And there's a couple different modalities of that we'll give. And so those have come out of scientific studies that were done where they found that it actually decreased the death. But it's hard for us to do that in the infectious disease world, to give something that's going to weaken somebody's immune system, because then we are imagining the same thing that would occur in a transplant patient where you weaken their immune system so that the new graft, as we call it, or the new transplant will take hold and won't just die within them. You have to weaken their immune system because that will go wild in those scenarios as well. But when we weaken the immune system, that's going to allow other infections that are being just harbored and kept at bay to run wild unharnessed, and that gets scary, because then you can see all sorts of infections like other viruses, like bacteria, like funguses, like mold, all those just run rampant, and we have to guess what it is that is causing them this problem, because we don't want to just shotgun them with every antibiotic and antifungal there is. we have to kind of narrow our treatment to specific things that we think is going on at that time, so that we minimize the side effects of these things as well. So that's the phase that's inflammatory, and right before that, the inflammatory phase. And then after that is where you see a lot more clotting that occurs. So that's where we're having to give anti-clotting agents so they don't end up with a clot in their brain or a clot in their lungs or in their legs or somewhere else. So that's a challenging phase. And then finally, after all this is said and done, a lot of us would think, well, you know, we may just get COVID and then we'll recover and we'll be stronger for it. Not always the case. And I'm not just talking about, well, yeah, you may die from it, but also you could have long-term effects of the disease that just go on forever and you never see the end of, like you mentioned earlier.
Yeah,
that is the problem that we're dealing with. Sorry, did you have something you were gonna say?
I think the most recent number I heard is 7% of people will have permanent long-term. That's the last I've heard. I don't know if there's been an updated number on that.
Yeah, and you know, it's unfortunate because even the most elite of athletes, you know, the Olympians, they're experiencing this, and it's at the heart level. So they're seeing long COVID effects on their heart with myocarditis. They're also having severe lung problems and other cardiovascular and other organ difficulties that are making it so that their performance will never be the same again. And that's somewhere at the percentage of 20%. And these people are young. So that's where one of the journal articles like JAMA came out with data indicating that 20% of those elite athletes are having this long-term COVID, post-acute COVID or SARS-CoV syndrome is what they're calling it now. That's the newer name for it. And so that's amazing. So you're 7%, yes, in the general population, but when you're talking about elite athletes, that's where they're saying it, because that's where they're fine-tuning this and really looking at any little nuance of change, any nuance of difference. So that's where even before you are performing and getting serious about whatever it is, like it's the Olympics or whatever that performance is going to be, those providers that are taking care of these Olympians or whatever are giving the patient vitamin D and making sure that their vitamin D levels are just right where they should be, because any little difference could make a difference. You know what I mean? Any little thing that you change is going to make a difference either for the better or the worse. And so if you want to have just excellent performance as far as running or gait or whatever it may be, their balance, their footing, if it has anything to do with running or et cetera, something similar to that, then the vitamin D may actually make a big difference as well as calcium for the general population as well. But that's where I think the fine tuning is individuals like that. And so that's the last phase that we are looking at. And so we're looking at individuals who may think this is a hoax or that it's exaggerated, and you either live or die. And yet we have this percentage of the population that are dealing with ongoing symptoms forever. And we've seen it with other viruses. This is nothing new. There's, like chronic fatigue syndrome and post-viral events after somebody gets Lyme disease. And that's something that we normally see on the East Coast and the New Jersey, Connecticut area. There's the little ticks that are inside the woods. People go out and get exposure to those ticks. They get this virus that causes Lyme disease. And then afterwards, they end up with this post-viral syndrome. So after their actual infection is gone, they end up coming back with fatigue, et cetera, et cetera. We always tell them, well, there's no chronic Lyme disease. And we don't really recognize that as an actual disease. And that's true, because we're not going to give them antibiotics for a bacteria when this is something that will go away, and then they'll end up with the post-viral syndrome after the fact. That is a problem. This is a post-bacterial infection. And this is where that kind of disease could cause the same or similar thing that we're experiencing now. With all the research they've done with post-viral syndromes, though, they haven't come up with any really good treatments, unfortunately. So now we're just kind of like hoping that all the resources that are being pooled together now will be able to address this problem with better ease. Kind of like with the vaccination process that we have. We're using a new paradigm for a vaccine, a new technology, the mRNA vaccine, something that's been around for 20 years, but we haven't been able to launch the way we have today because of the amount of money that's gone into this. And if you ask anybody that's in the vaccine industry, as far as the scientists go, they'll tell you the biggest factor for them being able to use this and seeing the success of it in such a short amount of time, because that's where the anti-vaxxers are like, how could this occur within a year? How could you have this vaccine that's going to come out and it doesn't have a microchip in it? It doesn't have nanoparticles. It doesn't have fetal products or something like that in it. How could you have that in such a short period of time without taking shortcuts and being a danger to our societies? Because all the money that's been put into this. And we've had the greatest scientists in the NIH and other organizations that have been able to really refine this process and take away some of the red tape that's been involved in the past, where it takes 10 years to get a good vaccine. Well, this is taken a lot quicker because this new technology doesn't require making a virus and then culturing the virus and then putting that virus in a certain form where it's killed and it's no longer active and can be injected into an individual. And that is where the vector vaccine like Johnson & Johnson is formed, or some of the other vaccines like the one from China. There's several other vaccines out there that are vector form, where it's a vector of a common virus like adenovirus that has material from the actual virus that we're trying to protect against, to then give your immune system the ability to learn from it. And that's where the sort of like side effects from the vaccine come in, because a lot of people get the side effects and they think, oh, it's I was injected with the virus, now I got the virus, what am I going to do? And that's what they've always said with the flu. They said, well, I'm not going to get the flu vaccine because I get the flu every time that I get the vaccine. And so it's not worth it for me to get it, when in reality, it's all what we call reactogenicity. And it's because of the robustness of the vaccine itself, where it's able to teach your immune system how the vaccine works and then protect you from having any major complications. And believe me, that was part of my publication process, is studying these individuals that are young, had flu, and then they ended up having some major heart complications from it, like things where they had an electrical conductive disorder of their heart that could have killed them if they didn't get to the hospital when they did. And so that was an amazing chance that I had to provide a publication with a group of people that discussed that, to raise the awareness to other people that yes, the vaccine is a good idea. Whether or not it's 40 to 60% efficacy, I think it's still a good thing to get it, because each time an individual get the virus in them, it mutates, and then it gets harder for it to be covered with the specific vaccine you're using for that year, because they try to change the vaccine each year to make it so that it will still be effective the next year. So say they'll study during the winter time, they'll be studying what different strains are in Australia, New Zealand, places like that in the southern hemisphere. And then when it's summertime here, they'll already have an idea of what strains are out there and which ones we need to cover for here during our winter time. And so that is kind of like where the paradigm takes us, because with the flu vaccine, we'll most likely be able to use the mRNA vaccine in the future to raise the efficacy for that when they're able to produce a vaccine with a much quicker process, and it'll be safe, and it'll also have that ability to be so effective, perhaps at a 95% effectivity, kind of like with the Pfizer and the Moderna vaccines. And so right now, that's really what we're learning so much about, is vaccinology, how it can be done so quickly, how it can be so effective and be safe for us, and to understand the data once they finish those 3-phase trials for both Pfizer, Moderna, and now Johnson & Johnson, and they've already completed some others like AstraZeneca, et cetera. And now we're able to evaluate that information with more clarity and be able to say, okay, so this is a good vaccine because of this reason or this reason. And in this case, with those vaccines we've had so far, where they haven't really had a lot of licensing opportunities like with Pfizer and Moderna in the past, we haven't had any other mRNA vaccines to be able to compare to. So now this is kind of new in that respect, but they've already used them for some time as far as in research opportunities. And so now we see that those vaccines are very good, but then there is some signal that they may not be so good with those individuals that have severe allergies. So we have to be careful about who we give them to. So if somebody has a type of allergy that we call anaphylaxis, where maybe they take a vaccine, or they get a bee sting, or perhaps they take a medication and all of a sudden their throat closes off, and they
Mm.
carry an EpiPen with them to inject in their thigh that will allow them to get the adrenaline they need to open up their airway again so they can breathe. Well, we probably don't want to give it to those individuals. So those are one individual we don't want to give it to. And also, I don't think was studied well enough during the three-phase trials in pregnant patients. So in the past, we weren't giving it. Now we're not seeing a signal that's negative in giving it to pregnant individuals that are now being vaccinated on a regular basis, because we think that if they get COVID vaccine, or if they get COVID disease, those pregnant individuals, they have probably 20% more chance than the general population of dying from COVID, just because of the fact that they're pregnant. And so perhaps it's okay just to give them the vaccine at this point, but we do like them to speak to their provider first to make sure that they're both on the same page as far as doing that, because it is, kind of like during the study, we're like, okay, it wasn't studied enough in pregnant people, so we don't have objective data that's that clear as far as its efficacy in pregnant individuals. But we do feel like it's safe enough to give to those that are nursing babies, because we don't feel like it's going to enter the milk to the baby in a way that's going to be deleterious or unsafe to the baby. So that's a good thing. And the other population that we don't know about are those individuals that are young. So in the case of Pfizer, individuals that are younger than 16 years old in their adolescence, or in Johnson & Johnson, as well as Moderna, those individuals that are younger than 18 years of age. So those are some of the things that we're learning. A lot of people were thinking that they could get something that's called Bell's palsy from one of these vaccines. And that's where it's kind of like a stroke, where one side of your face just droops, and that's really scary, because you think, gosh, am I going to live for the rest of my life with Bell's palsy? I had a patient like that who had a severe droop, and it was because of Bell's palsy. I thought it was a stroke, but in reality, it was Bell's palsy that did it. And so we're thinking, is this going to be something that we're going to cause in individuals? Are we going to cause them to get Bell's palsy? So which is going to be safer for me, getting the vaccine, or just, and they might end up with Bell's palsy. They might save their life, but they may end up with Bell's palsy for the rest of their life. Or do I just keep them safe, keep them away from other individuals, like the physical distancing and wearing their mask, so that maybe they'll be able to be safe up until the time we can give them a safe vaccine. But we haven't seen any signal of individuals getting Bell's palsy. There's another disease that we get concerned about individuals getting when they get COVID vaccine, or a lot of people were concerned about. But I think you get more of this disease by getting COVID-19 itself, and that is Guillain-Barré syndrome. And that's an ascending paralysis that starts from the feet up. It eventually ends up in your respiratory system. And that's how, if you don't get care, you end up dying because you're not able to breathe. And so it's a neurological disease that oftentimes is triggered because of viruses and bacteria. The most common one being Campylobacter bacteria that causes a diarrhea. And then after the diarrhea, oftentimes that ascending paralysis occurs. I had that disease years ago, and the thought was that I might have gotten it from a vaccine that I took. I don't know which one, because I got several at the same time to go to be a missionary in Brazil. And then I ended up coming back home a month later, paralyzed for a time. And so thankfully, over the years, I was able to get the care that I needed, and I'm at 100% again. So it is a concern for me, especially at the time in December, when it was time for me to get the Pfizer vaccine. I was thinking, could I get another episode of Guillain-Barré syndrome because of this vaccine? But we're not seeing any signals of that, and we didn't see any signals in the phase trials where 60,000 people or more were in the study, and none of them got it. It's better to look at it when you have 1 million people in the study. But overall, I felt comfortable with the data that was presented by Pfizer and by the FDA at that point, and the comfort level of them issuing the emergency use authorization for the vaccine. So I received the vaccine, and thankfully, I'm still able to walk and talk. So
Wow.
those are some of the major diseases we have seen that are more likely to be because of getting the virus itself, but not necessarily because of the vaccine. and that's kind of losing favor. So even getting Guillain-Barré syndrome or some major disease from getting a flu vaccine is also losing favor. We're thinking it's more because of the virus itself that's going to do it. So those are things that we're learning, and it's just an amazing evolution. A lot of times we think, oh, this is a moving target, but I think we're getting closer and closer to our objective of finding how safe these vaccines really are. And there's so many that are out there that have so much more knowledge than me. And I try to be connected with them in networks so that I can also glean from their knowledge of how the vaccine is working in their population, like in the New York area where they have such a higher number of patients, higher number of those that have suffered because of the disease and died, and a higher number that have been vaccinated. And so we're not seeing any signals of these major diseases we're so concerned about, and definitely no signals of any microchips or fetal material or anything like that in the vaccines. So that's a relief.
Yeah, I'm not afraid of the microchips because I mean, we got cell phones. Everyone carries a cell phone on.
Exactly.
We're telling whoever if somebody's spying on us, they already got it. If they are.
If there's any kind of mark of the beast, that would be it.
Yeah. So in December, you got vaccinated. When do you think? The last I heard was July. They think that vaccinations will be available for the masses. Have you heard anything different or any news on that?
You know, that is fantastic you bring that up, because I know President Biden initially said, hey, my goal is to get the vaccine out to everybody by July. And then just last week, if I'm not mistaken, he came back and said, my goal now is to get it to everybody by the end of May. And that's a tall order to get it to everybody, when you think about in the United States, only about just above 9% of all of our population in the United States have been fully vaccinated at this point. Perhaps a little higher than 25 have at least received one dose of one of those two mRNA vaccines. And now Johnson & Johnson is just starting. We know that's just a one-dose process. And so I don't know the percentages on that one. So I think we got a long ways to go. And I think that's just a daunting task. But I'm prepared to do all that I can to assist in that process too. I'm trying to get the vaccine available so that I can also vaccinate on my nights, so that I have my night job going after I have my day job going. So that's what I'm really hoping to do in our community, to hopefully contribute the best that I can. I work for a lab also, so I can also take that to the lab, perhaps if they're willing to also vaccinate there. And that will be another huge population in the Las Vegas area of those that may be, some of those capital of the syphilis individuals. So that'll be helpful for them as well, because there's a lot of close contact there as well.
What would your suggestion be for those that aren't vaccinated right now? I know the common things: wear masks in public, try to take vitamin D. Is there any other suggestions that you have on just living daily life unvaccinated currently?
Yeah, I just think that if I think it's a good idea to try to test ourselves as frequently as we can, to be, at least to be aware that there are like antigen tests out there. Those are simple, either saliva tests or they just do a little bit of blood. And if you're testing on a frequent basis and have an idea of where you stand, I think that's such a good idea, along with the things you're talking about with physical distancing, with masking. Masking is so appropriate and so necessary right now. And there's a lot more information that's coming out on masking, on making sure that it's tightly fit, the kind of mask that we should be wearing. And now the CDC is coming out with a new guideline. They just came out with it yesterday, as a matter of fact, in the morning, where the Center of Disease Control and Prevention has now stated that in your home and with other individuals of other families, if you're all fully vaccinated, or if you're in a low risk population, you may be unmasked, perhaps in those locations. That's not in public, because public, they're still saying that you should be masked. So I disagree with Mississippi. I disagree with Texas when they're stating right now that it's probably okay to be unmasked. I think in certain areas of those communities, there are a lot of people that are very conscientious, and they're going to be very careful with that. I just think overall it's probably not a good idea to just kind of lift that mandate, and also say that people can be in restaurants safely without problem in full service. I think that's probably not a good idea. Restaurants, okay, you got to live your life, but maybe perhaps with less individuals in those restaurants to give less risk is going to be a little more safe if you decide you want to go to restaurants and not just do the takeout option. But I know it's tough because a lot of us are so used to going to restaurants, and at least, a date night or something is good with our wife or our husband or whatever it may be. And, we have to make that decision, and it has to be an individual choice. But those CDC guidelines are really straightforward and I think really understandable. So I think those are helpful. And I think as we gain more and more trust for the things that they're doing, I think that helps, because I know that there have been some times where it's been a little touch and go of whether we're going to trust the FDA. I know back in the day when they were saying hydroxychloroquine was okay to use, and that just became a complete disaster because it didn't do anything for anybody. And it was a really sad situation. And I was glad when they finally revoked it, but it was way too late. And probably a lot of people got it and ended up dying of it because of its risk of causing electrical conductive problems with your heart.
Oh, I
Some
haven't
people
heard
would
of
have
that.
arrhythmias and they would die because of it. That, as well as the just reckless use of antibiotics, like azithromycin, that also would create this possibility of arrhythmia in individuals. And when you combine the two, which was a lot of people were doing because they're just giving everything under the sun to these patients, trying to save them. I know with our first patient, which was the first patient in Nevada that got COVID-19, he was in our hospital and we diagnosed it. I was like, oh my gosh, what are we going to do? And I think everything that was at least accepted at the time was given to that patient: anti-HIV medications, antibiotics, hydroxychloroquine, ribavirin, which was used for hepatitis C. Just everything you can imagine that was accepted at that time. And it wasn't that we were just throwing it at them. We were having discussions with infectious disease pharmacists. We were having discussions with the pulmonary critical care, with state. We're just, trying to network with everybody, trying to decide what's going to be best. And it was just amazing 2 or 3 months later when that patient walked out of the hospital. I was amazed because he had a rough course. He was intubated. He had a tube down his throat. He was on mechanical ventilation. The poor guy, he was in his 50s, so he's pretty young. And you heard about him, yeah?
I think I saw the when he got released from the hospital. It was on the
Yeah.
news. Okay, yeah, okay, I remember that.
Yeah, there was a big clap out, and that was just so amazing. And we were all so happy. And then we brought him back last week to get his first COVID vaccine, and just kind of were reminiscing, but then talking about what his issues are now. And he has long COVID. He has a lot of the symptoms that those individuals have when they have the post-viral syndrome now. So he's dealing with those, but it's just been a great thing to at least see him alive after he had to endure all that. And we didn't know what we were doing. A lot of times we still are not clear because now we're looking at the variants and we're thinking, oh, what are we going to do with these variants now? The variant of the virus where you get these different mutations, and you're like, oh gosh, does that mean that we have to treat them differently? Do we need to get the testing for the variants? We don't have the variant testing. Is that even necessary above and beyond like a public health standpoint? And then there's the whole thing about these patients, where are we going to keep testing them over and over and over until they become negative? Well, the CDC has said at this point that testing is important. When you have somebody who's negative and you suspect they're positive, you have to repeat that test to make sure, especially if they have symptoms, to find out when they're going to become positive. But when they're in the hospital and you're trying to decide what to treat them with or how to treat them, if you get a positive test and then you want to find out if at this point, maybe 2 weeks or 3 weeks down the line, are they negative and they no longer have COVID, it's not a good idea to retest them because they could be positive for months and they're no longer contagious for spreading the disease with other people. So I know it's a difficult decision process, but that repeat testing is not necessary. The CDC said it last May, so we're talking almost a year ago. And I know a lot of people weren't trusting the things that they were saying, and that just goes to show how there was a lot of distrust, there was a lot of division in our country, and that was definitely one of those places where a lot of people are like, I'm not going to believe what the CDC says, because they're just going to be backpedaling again later, and we're still going to be dealing with this disease, and it's going to be spreading to other people, and we're not going to be knowing why, because of the fact that we're not getting repeat testing. But we dealt with that. We had lots of employees that ended up positive early on in the game after a little trip or a little whatever they did, so they had exposure to other people. And we were keeping them home, waiting for sometimes up to 2 months for them to become negative. And I've had patients that have been positive for several months, and they've had no symptoms at all of COVID. And so that testing approach is just useless. We just test them one time, and then after that, we understand that they may have remnants of the virus itself within their nasal passage where we test them, but there's no ability for that virus to be viable and to spread to other people.
What's your thoughts on the Fauci mask comment? So about, gosh, how long ago was it now? I want to say April of last year. I might be slightly wrong on this, but on the timing, I think around April, he said masks don't help, but he was saying that to make sure that doctors and the first line people get the mask first. What happened is, like you said, or you're talking about the divide in people, it caused the divide. What's your thoughts on that, thinking back on it now?
Yeah, and that's an excellent question also, because I know that there are a lot of people that will criticize him and say, well, he really didn't know what he was talking about when he said that. And oh, wow, he really probably caused a lot of people to die because of that, because we haven't had any really consistency from then on. And I think that's wrong. I think overall, Dr. Fauci, I mean, over the head of the NIH, he was kind of in a learning process just like we are, and he hasn't lived through a pandemic, neither have we. And we really, I know in our hospital, we kind of fought that for a while, because we're thinking, how are we going to have enough masks to keep everybody protected if we continue to mask people and make sure everybody has a mask? And especially when, not even when you're talking about N95 masks, which are the most valuable and the most hard to come by. And they're the gold standard. That's what we really want. We want an N95. And so that was such a challenge around April, May time, is deciding whether we could really have enough masks for everybody. Of course, we wanted to have universal masking, but we were thinking, we didn't know if we could sustain that effort. And we're thinking, even at the level of the VA, where we have our own supply chain on that, and they have like stockpiles of this stuff, and still we were concerned that we were going to go in the red and run out of supply. We were looking at other hospitals in the area, much more massive than we were, that didn't have anything for their staff members, as far as they were just telling them, well, I'm sorry, you're going to have to bring your own. And how's anybody going to get any of this stuff? How are they going to get a surgical mask? How are they going to get a hold of an N95? How are they going to get a hold of whatever else they want to protect themselves? If they wanted to use a hairnet or a cover over their head, or foot booties, any of those things that are really not promoted by the CDC. But they didn't have any of that stuff for several months, until finally the manufacturers were able to send out large quantities of these things to different companies, and then from there to the hospitals. So we were just really in the same boat, and the guidance wasn't out there yet. The universal masking was the right thing to do, or it would help. And I know this was already something that China already knew about for sure, and not just because of this pandemic, but for ages they already knew. And I think overall, much of Asia was already doing it. My colleague right now is originally from Thailand. And I think Thailand, they had a fantastic way that they were doing. They had an epidemiologist as their prime minister. I mean, it was just amazing. And I think they were just so ready and prepared. And it's just a sad thing that here in our culture, there was just not a lot of acceptance for us. So of course, when it seemed like we were being so inconsistent with the words of Dr. Fauci, because he felt the same way, that we weren't going to be able to sustain our ability to protect everybody with masking all the time, that a lot of people just fought against it. And then I've looked at that in retrospect saying, oh, well, he just didn't know what he was talking about. But in reality, it was an evolution process, and it was a learning process. When we finally came to the realization in our hospital, it made a big difference as far as how many employees were then clustering with the different exposures that they were getting without us even knowing about it. And so as soon as we instituted the universal masking with the help of individuals from other hospitals in our area, wow, it just really made such a big difference. And then from there, we were able to really continue to make strides as far as protecting the employees and protecting all the staff members, all the volunteers that we were having coming in. And some of our volunteers are over 75, sometimes 85 years old, who would come in and work with us. So they were definitely high risk, and we were concerned about them. And so we were able to protect them, as well as, of course, the patients. And our policy is also to make sure that each of our patients are masked when our staff members walk in the room with them as much as possible, because as much as we want to provide them with a safe environment, with a room that doesn't have the ability for the particles of the virus to be around, called a negative pressure room, we're not always able to provide that in every area of the hospital. That's a challenge, and I think a lot of hospitals have the same challenge. And so in lieu of that, we cohorted or made sure that all of our COVID patients were in one place within the hospital. And so we called that the COVID unit. And we didn't only just do that, but we also sealed it up. And so we zippered it. And so everybody that walks in that unit has to be wearing all the proper PPE for the whole time they're there. So you can imagine a nurse that works there and works for 12 hours in that unit. They can't necessarily drink anything or eat anything while they're in the unit itself. So it's a real inconvenience. But it's the way that we felt was the right direction to keep not only the staff members safe, but also the patients, because we did have individuals at the time that you spoke of that had to work in different places they weren't normally used to working in the hospital at certain hours that they weren't used to working, like at night, etc. And they ended up getting COVID and had severe disease and almost died, and were, rejected by hospitals several times. Even when they called 911, they were assessed and told they couldn't even come into the hospital. So it was such a burden at that point of patients going into the hospital. And we were so puzzled about how we were going to, create a safe space like universal masking, et cetera, where we're really going to be able to have enough to go around. And then were we able to have the space that we needed to house all these patients, especially once we had a zippered up unit. And we got to even more of our peak in November and December of this year, where we just saw a massive amount of patients in all of the hospitals around us. And that's where the huge surge broke out before finally people started getting vaccinated. And we've already seen such a reduction in patients due to that whole herd immunity that we're starting to see, even with the small percentage of those that have been vaccinated thus far. So it's really been such a development. And again, I wouldn't say it's so much moving targets. There are certain moving targets out there, but I think it's still, we're just coming to a fruition on our understanding. And we were at a certain level that we were back then. And I still think that Dr. Fauci was wise, not perfect, but wise in all the things that he said. And he definitely led us in a direction that was appropriate for us. And then we could kind of use our own judgment and look in the literature ourselves and try to understand better how to move forward from there. Like certain things that the CDC would say now, I'm going to say, well, let's modify that and err even more on the side of caution and be a little more careful. Then we learn over time whether that was the right decision or not. But I think anytime we try to err on the side of caution and be more careful than normally we would, then I think we're going to be doing the right thing for our patient and those around them.
What was it like pre-vaccination for you? As in, I can't imagine going to work as a doctor, dealing with infectious disease. So, I mean, for you, or in the United States, we heard about COVID March of last year, somewhere around March. So for you, in your mind, for 9 months, from March to December, you're going to work. What's going through your mind dealing with COVID, protecting yourself? I just can't imagine being in fear of COVID the whole time working like that. I don't know. What thoughts were going through your mind during all that?
Yeah, I mean, it was pretty scary because I know it was at a time where the most of the pandemic, I was the only infectious disease person, and that doesn't mean that I was completely alone, because there were lots that were part of the team that were of other specialties that could be of great benefit. I just remember it was February when I was on a hike with a friend, and then we were looking in a news feed, and then we had heard about this new virus that was out there, and we're thinking, oh, okay, so we got another outbreak. So I wonder if we're going to actually see this one this time, because 2003, a lot had seen SARS. After that was MERS, and we saw some of that, and then was Ebola. But most of those didn't really make it to any great, extent here in the United States. And so we're thinking, okay, so that's something interesting. I'm going to have to follow that. I just had this feeling I'm going to have to really, see if this ends up to be something of major importance to us or not, or if it's just going to stay in China. And I remember as it continued to spread, my level of anxiety continued to mount as I saw what this could mean for us. And I remember initially we started having like meetings. So especially when our first patient was diagnosed, then we had to trigger what's called the executive leadership of our hospital came together. So it's called incident command. And at that point, initially, I mean, we just had immediate meetings where we're meeting together, trying to decide what we're going to do and what's going to happen if we get a surge of these kind of patients around here. And so that was anxiety provoking, because they're asking me a lot of those questions, and I'm thinking, oh, I was kind of trained to do this, but wow, it's really here. And I felt really alone, and it was very anxiety provoking. I definitely have a lot more gray hairs now because of all that. And so that was the start, and that was just after March. And then I remember I got a letter or a little note on my desk that was handwritten that said, please come upstairs to the administration office because a senator is here to talk to you. I was like, oh, and I knew it was going to be televised because public affairs was there. And so that was the next one, is myself and another provider that was from pulmonary critical care had a little interview with him. And mainly he wanted to know what was going on, what was happening, because this was the first patient in Nevada with this disease. And he wanted to understand it better so that he could assist all those around to make sure they were supported adequately, in this early stage of the process. And as he was doing so, also, he was asking, what could we use for support? What did we need from him? And of course, the biggest thing was we needed resource. So that was the big thing that we asked for at all levels, from the administrative powers that were working with me and were in that meeting with us. And so that's kind of how things started. And then from there, we started having a lot of virtual meetings. So these meetings were sometimes twice a day, and they were, throughout the weekends as well. And then, of course, lots of questions from the emergency room as they started admitting these patients. And I think the challenge initially was, how do we test them? How do we confirm this is COVID disease? How do we protect them? So processes had to be formed for each of these different nuances of the disease process, so that we can make sure that at every level they're cared for with the same kind of care we've given for every other disease, but it's something we've never seen before. So what do you do? And so we had to rely on a lot of our epidemiology information that we have, a lot of the public health. We had epidemiologists from the state that came to visit us, which was helpful. They offered their recommendations, but a lot of times they were like, well, it looks like you're already doing everything that would be helpful. So great, just keep on doing what you're doing. But as time went on, we saw that things were changing. We were learning more. So of course, we had to also change with the times. And so that's where we continued having different meetings. And that's where that whole zipped up unit idea came in. And one important aspect of that is trying to protect our supply of N95 masks, which are the best masks that we can have, that's just going to cover your nose and mouth with a tight seal. And they should be fitted properly. And if you have a beard, it's much harder to fit them. And some individuals, because of their face shape and form, don't fit properly either. And so that means that the N95 is useless for them and shouldn't be worn. So the alternative that we've had for years already, was something called a PAPR. And this is kind of like, it looks like a moon suit. It's like, if you ever see, when different places in the world where they are all geared up, some of them are wearing these, and it's kind of like a large sort of helmet that you're wearing. that blows up with air, basically, and the air is airtight, basically, so it stays within there at a certain positive pressure, so that things are blowing outward, so that you can't get these particles that are blowing inward in there. And this area here is all windowed, so you can see. And then the back part of it is hooked to a hose. And this hose is then hooked to a device that has a filter on it. And that filter is then filtering your air that's being pushed through there and with positive force to then push outward. And then your room is negative pressure, and the negative pressure is going to be blowing into an exhaust right out of the room. So that's the other protection, of course, that had to be thought about in different meeting processes as well. And that was another anxiety provoking thing, was all of these meetings that we had for all these different various things that had to be carried out. And we're at the federal level, so I think they're probably the best at bureaucracy overall. And so the PAPRs were one of the most successful things because we're not having to burn our N95s. And at some level, you can think of this as being 100% effective as far as keeping people from getting infected.
But those units still have a filter in it, so you guys would have had to change the filters on that too, though, right?
Yes, sir. So they are changed on a regular basis as well. So it's something like on the order of a monthly basis if they're used like for a 12-hour period during a shift or something like that. We're having to make sure those filters are, when we see that they're expired, make sure they're changed out, make sure they're operational, because I know that's been a problem recently, is just recognizing that there are papers out there, scientific papers that indicate that there's other bacteria and funguses that people are getting because of the PAPR itself, because it's not being cleaned properly and not stored properly. And so then the industrial hygienist needs to be involved in making sure that they're stored and cleaned and maintained properly so that they're still useful. So that we make sure the hoses are still proper, then there's no air leaks, and everything is working in proper order with those PAPR devices. But they're quite helpful. I've used them a lot. I used them before COVID because we have those that have tuberculosis for whatever reason that come into our hospital, and that is another airborne infection. COVID isn't always an airborne thing. Those droplets are not always in the air. It's usually a droplet thing where it just comes from the mouth and onto somebody else. Even if somebody's exhaling, even if somebody's talking, those droplets can come out. But every once in a while, they can float in the air. And that's where we get concerned. And it's more so of a concern if somebody has, like, say they need some oxygen that's blowing at high flow, those particles are going to be floating around with a lot more density. Or if somebody perhaps is on a nebulizer machine because they have asthma or something, or some sort of lung disease, and they have to be on a machine to be able to give them certain medications that will open their airway, that's another risk. And if somebody has to put a tube down the throat in the process there's all sorts of bacteria, viruses, and all that stuff that are floating in the air around them. So the person doing the intubation is going to be at high risk in that scenario. And so that's where aerosolization comes in. But tuberculosis is always an aerosolization issue. So it's at some level more dangerous, but it's more of an insidious disease where it comes on and kind of just smolders for a long period of time. And eventually somebody may die of it if it's not at some point recognized. And it could be spread quite easily to all the family members around them. And the good thing is we don't see it a lot here in our population. It's mostly in other endemic populations, but it's something we have to think about and recognize and not miss, And so those are some of the processes that we've been learning, is how to use the PAPRs, how to use some of these other devices to help to protect and keep everyone safe.
When you say COVID isn't always aerosol, what? So as opposed to tuberculosis, you're saying that's always it's going to always float in what someone's breathing, I'm guessing. So then with COVID, you're saying, I guess, what do you mean by it's not always aerosol? Like, is it big chunks or small chunks or?
Yeah, that's a really good question. I think that's probably a good way to explain it the way you just said, because the droplets or the organism itself, in the case of tuberculosis, is a bacteria. It actually is lighter in proportion to the virus itself, the COVID virus. And so this one can actually be able to be airborne, so be in the air when somebody's just talking or even just exhaling. that droplet can then be all around them in the air. So if you're in a room that's not a specialized room for these tuberculosis patients, you can easily get exposure to it and end up positive for tuberculosis. And it's all about the size, like you say. So the COVID particles are slightly larger, and so they then will then just drop right out onto the ground in most cases, unless they have a reason to be propelled into the air. Last year in Washington State, they had a choir that were singing or practicing, and during the process, there were a couple of those individuals that were sick with COVID. And because of the way they projected their voice, they spread it to other individuals, and several of that choir ended up dying after the event. And it was, of course, something that was all over the news. And we recognized, this is really something that can be propelled and become aerosolized in some certain scenarios. And so it's all about how you can project it or get it out into the air for that to then be a danger to other people at any given time. And the other thing that influences that is the ventilation in your home. And so sometimes if you have poor ventilation, maybe a smaller house or an apartment or trailer, whatever you live in, that could present a problem also for individuals getting it from other people, even if they have separate rooms, etc. This could present a problem in some scenarios. So masking at home was also a directive because of that. And so we've always tried to make sure that everything is science-based, so that we're not just kind of like, because of our experience or just kind of shooting from the hip, indicating that we should be doing something because of something a governing body has said. We want to make sure that's backed up by something. So I think that is where all that comes from. And aerosolized particles is part of that whole governing process and the things that we've learned from science that we now understand. In most cases, this is a droplet and contact disease, meaning that you could get it from close touch at the time that the virus is there and viable. But it's not so much going to be a contact thing from, say, giving money to other individuals or giving something, some paper object or some inanimate object to somebody else. Fomites is a term we use when we say a virus or some sort of bacteria or something is on that inanimate object that we're passing to somebody else. That has not become such an issue. I know early on in China, they were talking about the origin of the virus, and they thought it had to do with the frozen food in that market where they felt like it originated from. And so a lot of information has gone out about this frozen food and how it could have spread the virus. But we're not seeing that as a cause today. We know that it came from an animal to then the human and was able to make that jump. And from there, it's been a person-to-person thing from nose and mouth from then on. Not even anything from the stool, like if somebody has diarrhea, it could get into the eyes and that could become a problem. But for the most part, it's a respiratory disease like all the other all the other coronaviruses have been. And it just happens to be the newest of that flavor of disease because maybe thousands of years is where the common cold began, and perhaps it was the same way and wiped out a lot of people. But eventually, the future generations ended up getting enough of their own immune system for it, and it has become just a common cold and nothing more. And it's never anything significant for us today. But we don't have thousands of years for us to hopefully be, to gain that protection today. We want everything here and now because that's how we are today. So the vaccine has been a great help for that.
What's your thoughts on when you see people in public wearing the regular face mask, but also like a clear mask?
Oh yeah.
What's your thoughts on that? Is it overboard? Is it smart? What's your thoughts?
Well, my thought is when you're out in public, oftentimes when I go to the grocery store, especially before I was vaccinated, I would wear my surgical mask and I would wear at least goggles because that would be the kind of the similar thing to using a face shield.
Yeah,
And that's
yep.
a big clear thing.
Yep.
The face shield is probably slightly better, but I use goggles because it's going to cover that whole region around the eye and
Yep.
around this edge as well. And so that's what I've usually used. Even when I go to like a church congregational meeting, I'm going to be wearing my goggles as well, no matter if I'm the only one there wearing it. I don't care if anybody else
Yeah.
doesn't follow me do that. I'm going to do it. And I'm going to do it in the grocery store for sure, especially back when everybody's buying up all the toilet paper and the aisle for the toilet paper is completely filled. You just wouldn't believe all the people that were in those grocery stores at the time buying up all the
Yeah.
toilet paper.
Yeah.
And they would hoard around that. And as soon as people are over there stocking it, they don't even let you in the aisle, man. All the people that are around there, and then as soon as
Crazy.
it's stocked, they just go and grab it, and you don't get even a little bit of it. It's like, what the heck? And so, yeah, those things. So I think that the CDC did come out with guidance regarding that, as well as other governing bodies, based on the scientific evidence that it is a good idea to protect our eyes around that whole masking area. It is important for us to use the right kind of mask as well, because usually cloth masks are not enough unless you're using a second mask underneath it or outside of it, because we're talking either an N95 or using the double mask approach. Now, usually I've just used one surgical mask and just make sure that it is tightly sealed at the edge, whether that means I'm looping it here or putting a knot in it, doing the little tucking that you can do. There's lots of different websites now that'll show you how to do this so that you get a good seal on all sides of the mask now, because that's really the whole approach for why the N95 is so effective, because you can really boost the efficacy of that from something like 50 to 60% to 85% just by knotting it. And so that's pretty significant, because I don't necessarily want to be outside running, because I like to jog or run. And I don't want to have such a tight fit mask. It's hard for me to run. And so if I do, I'm going to make sure that it's going to be something that's useful, something that's pliable and I can still breathe in, and something you can train to do for sure. But yeah, you got to be able to still live and do those things that you normally do so you can, continue to be healthy as well.
So I'm gonna tell a story kind of related to this mask thing, and it'll probably make me sound like a stupid person for doing this. But so I went on a vacation, went camping last week for in California, and there's a hike from my campsite to the beach, and there's like sand dunes about a half mile or so. And as I'm hiking there, I'm also carrying like a 20-pound bag of snacks and food, and I had a little small tent that we're going to prop up at the beach. But I didn't have my mask on because I'm thinking I'm outdoors. If somebody walks on this trail, I don't think I'm going to catch COVID by just walking past them now. Or maybe you could add your thoughts on it after I'm done with the story. But as I'm walking, as a group comes up, and I don't put my mask on, I'm carrying this heavy bag. I'm like, I'm not going to reach into my pocket and try to get this mask on. We're outside. I don't think but I'm in California now, and I think their thoughts of COVID is quite different than here in Las Vegas. So they're giving me the stink eye. They're like looking at me like why don't you have your mask on? And I'm like sweating, carrying this stupid 20-pound bag over sand dunes to get to this beach. So later on, I tried to, in those settings, I tried to get my mask on more. But my train of thought is outdoors. I just didn't think it would be a huge risk unless I'm standing with them, talking with them. Then I'll tell them, hey, I'll put my mask on or something. But if I'm just passing somebody, and especially it's outdoors and the wind's blowing like crazy, that was kind of my stance. I didn't think it was that big of a deal.
No, I agree. I think it is. I think just some of those mandates, like Massachusetts has that right now. They're allowing everybody to go in the restaurants without any restriction. Okay, but
Ooh.
yet they have this mandate indicating that even if you're outside, you need to wear your mask. Doesn't make sense. I don't understand the logic with that. Making people always have a mask on outside, but yet in a restaurant you can just have that place packed.
It should be
Like
like
no balloon,
opposite.
And yeah, it
Outdoors,
doesn't make
no.
sense.
Yeah, outdoors, no
Yeah,
mask. Indoors, always a
yeah,
mask.
yeah. So most of our risk has been in restaurants, in pubs, in bars, in social clubs. That's where most of our risk for catching COVID has been. But outside has not been as much of an issue. I know of a lot of people that just go outside for a walk without their mask. I don't even think it's an issue if you don't have like masses of people around, and like you say, you're not with them right in front of them, because like you say, I mean, the air is dispersing all of those particles if there are any. So the likelihood of you getting it is low. And epidemiologists have said the same thing, because a lot of people want to gather. And, during the winter months, it's hard for us to gather inside. So, of course, outside would be the option that would be optimal in those cases.
Yeah. Yeah, it's been, I think I haven't been to a restaurant since March of last year. And every time I go out, I mask up. I don't wear eye covering now hearing your thoughts on it, maybe I should. um, yeah, I hope I hope the vaccine comes sooner for the masses, so then that topic I don't have to worry about covering my eyes. Um, Maybe I'll get some like indoor glasses or something, or yeah, I'll figure out something to cover my eyes
Yeah,
up.
even glasses are good, whatever. Yeah. I
Yeah,
think the risk isn't as huge having to make sure that your eyewear is on, but it is something that's been talked about, it's been discussed. So.
yeah. Um, During so March, April, May last year, I'm assuming. What were your thoughts going to work? Did whether you're afraid of getting COVID while going to work, dealing with patients? I'm assuming you're even more covered up at work with PPE, but there's still the fear of possibly getting COVID for you. Was that going through your head at all?
Oh, absolutely. Yeah, I think, because there was enough uncertainty out there, and the way that the media was just that all the information that was out there already, it was just scary. And so I think, most providers would try to avoid being in patient rooms as much as they could, and that was to the detriment of the patient. But at some point, you just have to say, I'm going to have to bite the bullet and just protect myself to the best of that I can, and just be in there and just do what I need to do. And I think that's what a lot of the infectious disease providers and pulmonary critical care and other places that I've noted have done is, I mean, they're just geared up from head to toe with something that's just going to cover them during the whole time they're in there with as many patients as they need to be. And I think as the time has gone on, that fear has subsided a lot, just because we understand better and better how to protect ourselves and know that, yeah, I can avoid getting this disease. There's no doubt about it. I just have to make sure that I'm vigilant. And I think that's the important thing, is consistency and vigilance, with even our hand washing that has to be frequent, and changing our PPE, donning and doffing it appropriately between each of our patient interactions, and just watching every single move that we are performing at those moments. That's really helped to decrease our fear. And I think just reading constantly about this, trying to learn to a greater degree over time, has really helped to ease that anxiety a lot, because I know initially I was quite anxious just like anybody else, especially when I saw such a surge come about. When you see such high numbers, you're like, oh my heavens. And I had so much work to do. I mean, just like every Saturday and Sunday to have all these new patients to see, and it was just such a load, and I was tired, and that's where the exhaustion set in with all providers in general. And you just hear these feeds of these different providers and nurses, and they're just like so tired. And I remember one nurse was like, she would work 12-hour shifts a day, go home, and sometimes longer, because maybe your replacement doesn't get there on time, or you just have some issues you have to deal with. And then she would get done with 7 days in a row or something, and then she would have to go grocery shopping, and there's no food, or there's no toilet paper in the stores, and she's
Oh,
just bawling, just crying, and you
oh
just, so your heart
no.
goes out for her. You're thinking, oh my gosh, well, how could they do that to you?
Uh,
And I think a lot of us have faced that, where you're having to really just, like I say, bite the bullet and just do the best you can with the exhaustion as it's setting in, and sometimes the burnout, because you just kind of feel it. And I was like, nah, I'm not going to experience any burnout. Come on, I did all this training, and this is what I prepared for. This is what I trained for. I'll be fine. But I did feel it, and it wasn't until I finally had some relief where I saw the numbers come down and I didn't have to attend so many meetings. I didn't have to see so many patients all at once. And I started feeling, oh, wow, I was really burned out. This is so much easier now. Wow. It just kind of like over time, you just don't realize it until you're like, okay. It's kind of like maybe perhaps in my case, I'm starting to realize that I have to use reading glasses now. And then when I put on my reading glasses, I'm like, oh, wow, I can see. I've not been able to see when I'm trying to struggle to read something,
Do you still enjoy your profession?
I do. I think this is really deepened my love for it even more, to understand it better, to grow with this experience, to overcome a lot of the anxiety I had for the public. This has helped so much to get me out of my comfort zone and out of my shell, but to learn much more as well, to be informed, to go much deeper as far as my understanding of how viruses work and how different antibiotics or antiviral agents work. The networking, all of the ability that I've had to make friends and to grow in our relationship, our association with others, with different colleagues, and just to overcome some of the weaknesses I had and that I still have, but at least they're getting better, because you start realizing, oh, wow, I wasn't very good at that. Whoops. And that, just even articulating what I want to say has at least gotten somewhat better, because I think it was a lot worse before. But I think in also dealing overall with anxiety when it comes to patient care, because I think you just want to do the best you can for the patient. You're always so concerned about something going wrong, about just, giving the wrong kind of care. And this has really helped to improve my confidence level so that I can know that what I'm doing is right, that I'm not alone in this, that there's always other people around, and we can work together as a team to be able to offer the best care that we can for these individuals. So yeah, I think that I love it a lot more. I never imagined that I would like this profession as much as I do, even after all this and after all the burnout and after the exhaustion.
What do you think are some of the frustrations or challenges that you faced in your job? Or
Yeah, I
some of the
think that
biggest ones?
probably the biggest one for me is, and I guess it's also an opportunity to share and to help other people to recognize that this is real, and that there's no need to be divisive in this. There's no need to weaponize different things of this process. I think that's been the most frustrating, just seeing, like January 6th when the White House was invaded, and all these different things that have occurred during this whole process that have made it much more challenging for us, because we're just trying to save lives. We're trying to keep people's awareness out there. And a big part of what we do, obviously, in medicine is just education, because we just want to inform the patients so they can make the right decision for themselves. And that's really, I think, where frustration has been, seeing how many are just totally closed off and sometimes narrow-minded. And, I look at myself. Am I narrow-minded? I hope not. I hope that I can be as open-minded as I can and be able to articulate these things in that way. But for me, that's been the biggest challenge. And I think the other thing is just getting the information that we need in a timely fashion, the care that we need to give in a timely fashion, being able to provide those things in a quicker fashion, because sometimes we want things now. And definitely in our generations, it's all about the here and now, especially here in America. We just want it now because that's what we're used to. That's our culture. And so I think we become impatient. So I think this is definitely a virtue I'm learning, is to be more patient and realize everything's going to be okay. It's going to work out. So I don't need to get too frustrated. We're going to get through this. So those are, I think, the biggest of the challenges that I've faced in that order. It's really been the divisiveness, and how, even just masking, there's been so much controversy when it comes to even masking. After that initial understanding that universal masking was so important, it's just, we're always going back and saying, hey, masking isn't really that important. It's all about controlling, and this is how we control our population, et cetera, et cetera. And we're not focusing on the most important thing, which is protecting ourselves from a viral disease, from something that's respiratory in nature.
I watched I think it was a short documentary about 20 minutes long. They're describing that these these viruses are going to be something more, and every 10 to 20 years, they think. What's your thoughts kind of on that? So if they're saying that, say, SARS, MERS, COVID, um, there are other people, like, say, in the public that don't understand diseases at all, that people that have no medical background or don't even watch the news, and they're like, what is this virus? It's COVID. We've never ever had anything like this before. But like you just, like, I agree with you. 1918, we had the Spanish flu, and we had bubonic plague before that. We had all sorts of things over the last thousands of years. But some uh, scientists are theorizing that as our world is getting more populated and airplanes and transportation is going faster, our trade is connecting people more and more. And they're saying something like 10 to 20 years, they think some type of pandemic disease is going to happen. What's your kind of thoughts, I guess, on that?
Yeah, and I mean, as I kind of alluded to earlier, just every year there are individuals that are dying, and they're dying of new viruses that get out there, but may not be successful enough to spread as quickly and successfully as SARS-CoV-2 has. So we're dealing with this on an ongoing basis with different diseases. It's just that every maybe certain number of years is where it becomes a larger outbreak and maybe an epidemic, and then from there a pandemic. And so I think it was just only a matter of time, and there were many individuals that were kind of predicting that this was going to occur because of all of the different things that you mentioned just now. We're just making the conditions just right with all of our international trade, all of the ways that we bring the world to us in many ways. And the fact that our population is growing so vastly because our medical care overall in general is improving. And we just don't have enough space for this. There's so many areas like India and other places that are so highly populated. And New York, I mean, there's just, I lived over there, and so I know how nice it is to have private space, which is kind of not very heard of in the southern area. These are things that are just going to continue to be an issue as time goes on. And I don't know if it's necessarily that these viruses are going to become more and more successful, but I think that there's a chance as we continue in the direction that we're going with our trajectory that those successful viruses could end up having more successful spreading ability to spread. It's perhaps true that that could occur. I don't think it's a matter of if, but when that we'll be dealing with this again. And I hate to say it, it's so pessimistic. And I don't like to be pessimistic because I like to be optimistic, just like anybody else, full of faith. I just know that we're going to continue seeing this on an ongoing basis, and we're not going to get rid of COVID-19 either. It's still going to be around at some level. It's just going to be hopefully a much smaller and more manageable level than what we've been dealing with. So I don't think it's going to be like the Spanish flu of 1918, where it's going to completely disappear with this nice little bell curve and it's gone. I think we're going to still see it as it's now at a plateau, and perhaps it may rise a little bit. I mean, we may still see some, little roller coastering. I'm hoping we're not going to see a surge that we've seen before with the variants, because that's really what we're kind of watching closely at this point to make sure that that's not going to be an issue. But we expected that was going to happen as well. We expected that we would continue to have lots of mutations because the virus wants to survive just like we do. But there's it's amazing all the research that has been done because of the WHO and because of all the Chinese scientists there. They have great science in China, and they have studied lots of different coronaviruses that are very similar to this. In fact, in some of the areas of Southeast Asia, they have been doing studies recently that their work has been published about, and it's all about very similar viruses to COVID-19 or SARS-CoV-2. And so they studied it, they found it, and that helps us to understand the origin of this virus, because there's so many that are still saying that they think it's man-made. and that it was because of China wanted to give some sort of biological warfare for the rest of us to wipe a lot of people out. When in reality, there's no evidence that that's the truth. All the evidence points towards, including these SARS-CoV lookalikes that are very similar, that it's a process of evolution, that there are different viruses at different stages that are very similar, that have very similar sequences to this. And they're finding them in random places. They're not finding them in places where there's laboratories, where they're just popping up. So these aren't those that can latch on to our respiratory system yet, but I think they could end up getting that sequence eventually where they could. And so I think we'll continue to learn about that, and we'll continue to see different outbreaks. And so now what we need to focus on is preparing for the next one, allocate resource for that. And I think that's the direction that we're going into now. And I'm so glad we're connected back in with the WHO. That's wonderful, because we need that kind of science. We need that kind of research that works with our Chinese neighbors, so that we can continue to battle against things like this is just for all of our benefit. You know, we can end the divisiveness, and we can continue to work together as a people, as a humanity.
When you said that you don't think COVID will have an ending bell curve like the Spanish flu, why, or what's going on in your thoughts when you say that?
Well, I think it's because of the research that we're seeing now. It's because of the direction that the mutations that are part of the different variants that are being seen now in sequencing are leading us to believe. So all the research now is showing there's lots of different variants that are popping up, and this is just a grouping of different mutations that doesn't necessarily make it a new strain. It's not a new virus or anything, but it's just a different variable, or a different just an alternative virus. It's just I can't think of another word to describe it, but it's so you have the SARS-CoV-2 virus, and just an alternative, just similar to that, kind of like if you have a language and you have a dialect of that language, which is just similar. It's the same language, right? But it just has just different words that are part of that language. Okay, like this, the Spanish language is in lots of different countries. It's the same language no matter where you go if it's Spanish, but there's lots of different dialects: the Cuban dialect, the Nicaraguan dialect, the Mexican dialect, etc. That's the same thing with the variant. You've got lots of different dialects of that virus. And they're not necessarily a new virus, but they're heading in that direction, okay? And so now you have the simple bell curve with the original flu. That is because of how that virus was and how it interacted with people. And eventually it died away, and it wasn't successful anymore. This has such an ability to mutate that it has the ability to survive, because it is mutating itself to survive, to provide that resistance against what we want to provide as a vaccine for it. So let's look at what I treat just about every day, which is HIV and hepatitis C. If somebody has HIV, there are medications that we can give them, maybe even a 1-pill regimen, where they can they can completely have that virus suppressed, and it's not going to bother them throughout the entirety of their life if they continue taking that medication every day. So they can live almost the same number of years as we can without the deleterious effects of different infections that are really what kill those individuals, right? Because all it does is it's just downplaying their immune system and allowing for all the other virus, bacteria, and things like that to cause them to get sick and die, okay? And so now, if that individual for some reason stops their medication at some point, they think, you know what, I'm fine. This is all in my head. I don't need these medications. I'm going to live without them, and I'm going to continue working and living my life. Well, if they do that, they run two risks. First of all, that the virus is going to be just like it was when they first had the disease before they ever started the medication. So their virus will then rise to a point where it's out of control, And then that will affect their immune system, and their immune system will then deplete and they will get weaker. And then the second thing that's occurring is the virus is figuring out how the medication works as it's not around anymore. Then it's mutating. And so then when you try to introduce that medication again, when you're trying to get them back on track, that medication may not work again. So then we do what's called a resistance test. We look in the blood and we take a look to see which medications may work. And we find that there's several of the medications that we wanted to try on them won't work anymore. And we see that there's several different signature mutations that allow that virus to succeed and to continue to cause havoc within them. And we can't do anything about it if we're using the same medications. So we have to continue to seek out those medications that are not affected by those mutations. And that's the same thing that's occurring with SARS-CoV-2. We're not concerned about it so much right now as far as our vaccine, but there may be a day in the future where our vaccines won't work. And that's why this new technology is also much more helpful in this new platform of mRNA vaccines, is they're not only easy to produce, but they're also easy to change. So you can easily tweak those vaccines so that they will cover those different mutations that we're concerned about. And that's why I think at this point, this is going to be an ongoing thing, because we're going to still be backpedaling. We're going to still be trying to have to tweak these vaccines time and time again, boosting it, because we're going to still see disease out there. And the duration of how long we're protected is not clear yet. That's the other problem. And so we're still working on this, and we don't know if they end up getting a new strain, get reinfected with something different, not a strain, but a variant of that strain. And then we're not sure if they're going to be completely protected, and they may end up getting sick, and then it may run out of control in that individual because they still don't have the level of immune system they need. So I think that hopefully that's clear that what we're dealing with now is it's all about mutations, and it's all about how the virus is trying to succeed. And it's also living the Darwinian sort of evolutionary process, trying to stay alive just like we are. And so the challenge for us is trying to stay ahead of the virus. And I think that's what we haven't done very good at, especially in our previous months here with all the deaths that we've seen that have been, I think, overall pretty avoidable. There have been a lot of deaths that were probably very avoidable if we were a little bit more apt, a little quicker with our approach, and stayed ahead of the virus like I think they've done in other nations like Thailand and China.
Yeah. All right, I'm going to go into the final question section. If you think of anything that you want to bring up that's not related, go ahead.
Thank you.
First question. What daily habits do you have that greatly improve your life?
Okay. Yeah, that's a good question. I really like that. So I think for me, I'm such a creature of habit, and I like to be consistent in the things that I do every day. So I'll just be very personal with you. When I get up, for me, it's a lot about prayer. It's a lot about trying to improve my own faith and my closeness with the divine being. So, and I'm not the best at this. I'm not the most spiritual, but I definitely try to utilize the things that I've learned in my faith to try to safeguard myself against all the deleterious effects of burnout and exhaustion, et cetera, that could occur. And so that's the first thing that I do, is get up, and that's what I'm doing. And then it's also about trying to study on my own, learning and growing each day. And that is so helpful for me, is in order to be able to share things with other people, I need to fill myself with something. So that's what that's all about, is learning new things, so I'm not repeating the same things all the time and boring people to death. So hopefully I'm learning new things and sharing new things with them every day. And I've taken on the challenge of, when we have this call that we have to have with the leadership of the hospital, and they oftentimes just ask me for a simple report, but then I go on and tell them new things that are out there that are important for us to know. And that requires some reading and understanding and learning. So I'm not saying anything that's wrong, because I'll be corrected. There's no doubt about it. There's other people that are listening to the call, and they'll correct me if I'm saying something wrong, which is good. And I have no qualm against that. And so that really helps. And I think it's just starting the day that way, keeping a prayer in my heart throughout the day, and then in the evening is my family time. And I think that's such a safeguard also against some of the isolation, the loneliness that we experience during a pandemic. Just being there with my family, that is such a great thing. With my children, with my wife, having the chance to be together for even a short period of time, with those long hours I put in. And I'm so tired, I just take the time so that we can at least talk a little bit and ask each other how our day was, eat a meal together, something, so that we can then be able to, sort of, have at least a good evening so we can reflect on the day and then improve things for the next day.
Yeah. What do you know or think of cryptocurrency?
Oh, yeah, cryptocurrency. So I don't know much about it, but I know that my son is into that.
Oh, really?
Um,
Okay.
yeah, he's starting to learn about it and he's investing in it more and more. I just don't know enough about it to really comment on it the way that I'd like to. So I probably won't say much more about it.
How old is your son?
He's 21.
Okay, okay. Yeah,
Yeah.
I'm huge into cryptocurrency. I love it. It's the decentralized nature of it, the programming of it is beautiful. If I like that someone has once described cryptocurrency as the culmination of the internet. When the internet, before it started getting publicly adopted by the masses, people thought it would be the great level, or what's the word I'm looking for, like where everybody could voice their opinion online and it would make everything equal. But that kind of actually, the internet didn't exactly do that. We got things like Facebook where it's a popularity contest, Instagram, same thing. And you got big media corporations, and even especially your internet service provider is actually a big proponent of this, where they control the backbone of the internet. So they have very big control on what you potentially could see through the internet. Not that they're blocking a lot of stuff for you to not see, but they have control of it. So that it's not as decentralized as the programming nerds that what our ideology of the internet should have been. So I think cryptocurrency brings the algorithm with there's something called RSA encryption, which every computer could have a key that's very unique to it, and no one could hack it. Not within reasonable means. It would take for one computer to hack one other computer's wallet or private key. It would take something like a 1 with 70 zeros. That's how many years. It's basically the time of the universe for one computer to hack the wallet of the other computer, or the wallet identity or password of that other computer, or whatever you want to call it. So anyways, yeah, I'm huge into it. If you ever have questions, feel free to ask me. I'm a programmer, so I look at it very technologically, and yes, I am maybe I'm slightly biased on the hope that it will revolutionize the world for the better. So I want humans to take this on and make it a better place. I sometimes question if humans have the right morals to actually go forward with cryptocurrency and actually use it for the right causes. But that's what I'm hoping it does, and I do think it's the future, because the genie's out of the bottle and you can't turn it off.
That's cool. I'll have to learn more about
it. Next question: what's the biggest problem nationally and or globally? What should humans do to fix it?
Yeah, I guess for me, national, globally, there's definitely a lot of prejudice, a lot of racism. Different countries that I've lived in, that's at least what I've seen. My wife is Latina, and so even though you see me as somebody who's Caucasian American, it's not that way when I'm with my family. And we experience it, we see it, and definitely, I try to be in those populations. Like when I was moving to Las Vegas, I remember a friend of mine knew Las Vegas a lot better than I did, and he shared a map with me of Las Vegas, and he asked me, "Well, what part of Las Vegas do you want to live in?" And I said, "Oh, this is the region right here," because I kind of knew what population would be there, and it would be more. It was more similar to what I was used to in New Jersey, and that population would have more African American, more Latino, that sort of population, rather than something like in Summerlin or in Henderson, where it's vastly white. I thought this would be a lot better for us because that's what I'm used to. That's what I like. That's what I grew up in. I grew up in different foster homes that were of different backgrounds. So I think that's one of the biggest things for me that's so frustrating is see all the prejudice, and especially now something that somebody pointed out to me, a good friend of mine from Pakistan. He mentioned that, he's always had a lot of fear and retribution because of where he's from and his political, or I guess his, his religious background. And there's a lot of people who are so against Muslim, and people that come from that area of the world. And so he's always scared of what would happen. Like one time he said the FBI contacted him because of the fact that he gave a reference to somebody in Pakistan who was a physician who had worked here for a while, but he went to an area of, I guess, an area where he was living where it was a restricted area, and he didn't realize where he was. And then somebody saw him going around in that area, so they got in touch with the FBI and got him sent back to the Pakistan. And so my friend sent out a reference letter for him so he could hopefully get him back here, because of course his job depended on him being here and his family was here, etc. And so the FBI actually contacted him for years after that, just because of that reference.
Oh, geez.
And just because of his background and where he was from. And he pointed out the fact that to me that was fascinating, that for so many years there was so much, I guess, publicity of those terrorist activity amongst Muslim. And now it's really changed. There's been much less of a focus on that. And now it's all about the terrorism, Caucasian people, like the KKK and things like that you see have really risen. And for me, that is just, all of that is just so frustrating. I think it's just such a huge problem that we have, especially here in America. I personally saw it less when I was in the UK when I lived there for the year and a half we were there. I didn't see as much racism. Perhaps it was there. Perhaps I just didn't see it because I was busy studying or whatever. But I see it so much here, and it's so unfortunate that we see so much racism. And that's one of our biggest roadblocks or problems that we deal with, barriers every day, is how much prejudice and racism there is out there today. The fact that we separate ourselves in different groups, like political groups or whatever it may be. And there's talk out there for a third party. I don't know if that's ever going to materialize, but that would be crazy, having three parties. So anyway, I think some of those things, I'm not so good at talking about some of those things, but I think, it's not like medicine to me, but it is things that I see and I think about a lot. We all want to make sense of the life around us, and we want to be around people that are like us. And me, I don't know, I've always had to adapt to different situations growing up with different foster parents that I've lived with and different areas that I've lived with. So those things don't matter as much to me. Thankfully, maybe I think, I remember I took a political science course years ago. And one of the things the teacher told us, I remember the professor, he says, all of us are racist at some level. And I always thought, no, I'm not racist. What are you talking about? But I think we have to all think about that we all have weakness there. And there's just no doubt about it. So we just have to check that. There's always going to be a check and a balance when it comes to that as well.
Yeah, that weakness word is a good one. I think all of us have some type of weakness. I had a conversation with a social worker that's like more like a psychologist, where she deals with veterans that have mental illnesses related to either PTSD, and they just opened a gambling and alcohol section or department. So I was able to ask her some of those things like, are humans, are we just doomed? Are our minds just set for either racism or negativity? Like maybe tribalism, Facebook, does that just add to the tribalism? Does Twitter add to the tribalism? And her answer was, yeah, it's looking pretty bleak for humans. I was like, oh shit.
Right?
uh,
Oh man. Well, I
um,
guess you have to be practical. You have to be realistic.
yeah. On the racism or my personal story on that, um, I feel like it's either a combination of heightism or racism. So I'm a short Asian guy. I know I'm very fortunate. I was born in America. I know English very well. I have a good job. I have a good salary. But when I look at some of my counterparts that are either tall and white or actually, have I had a tall Asian counterpart that got so the tall and white counterparts, people that I worked with that had nearly the same amount of experience, the same years of working in the field, and their promotions were just so much faster than mine. Like I have one friend, me and him went to high school together. We went to computer school, college the same year. We got into the IT profession the same time. Every step of the way, he's been 40% more pay every single time. And I have some friends that know both of us, and they said, I won't say his name. I don't want him to be upset.
Right.
But I have other friends that said, hey, I know you and him uh, work in the same field, and you talk about your troubles of promotions, but you seem so much more smart in IT than him. And I'm like, yeah, well, that's just the life that, I mean, whether it's heightism or I don't think the Asian thing, because Asians are kind of using, whether it's pharmacy, IT, or hair salons. But I think Asians are pretty well known in IT, I think. But so that's my side of it. Yes, I'm fortunate. I have a good salary, but it wasn't a road that I enjoyed when I looked at other people's journeys.
Yeah.
So, second to last question. Think of at least two people you know personally that should do this conversation. Call them out.
Let's see. Well, I think two people come to mind that are actually pharmacists that I think are just excellent. One of them is the one that I referred to that's originally from Pakistan. His name is Shafiq. And he is really well-rounded. He explains himself very well. And I think overall he gives a good perspective and outlook to lots of different aspects of life. So he would be one that would be called out. That would do a really good job, actually.
What was
So,
that last sentence? The volume
oh,
cut out.
sorry. Yeah, so I think he has a really well-rounded perspective, and I think he would give a good context to what you're trying to describe and share with the public.
Oh, that'd be awesome.
I always enjoy listening to him. I always learn something. So he's one of them.
Awesome. What was his name again?
Shafiq.
Shafiq. Okay, awesome.
Yeah. The other one is one that was working with us for a while, a very young person that graduated from pharmacy school not long ago. And she's also well, just the same as Shafiq, she is in infectious disease pharmacy. So she studied something specific in pharmacy. So we've gotten to know her as well as him just for the fact that they work in such close proximity to us. And she's since moved away. She's now living in Houston and working at the VA there. But I've always enjoyed listening to her perspective as well. She's also originally from, well, her family's from Pakistan. I think she probably was born there as well. But she's got a great outlook on those things. And I think I just really like the way she explains things because it's so clear and, just gets to my level as well so I can understand what she's saying. And so I think that those two, for me, would be excellent because they've got that kind of perseverance and understanding that it would take to have a conversation that is definitely less formal, and I think it is conversational, and yet I think you could get a lot of meat out of what they're saying.
That's awesome. I find that doing these conversations, um, when people get into their career and it seems like they go above and beyond because they're so passionate about it. Like I see it in you, I see it in quite the majority of the conversations I've been in. There was one with a physical therapist. It was funny that morning when I woke up and I was like, I don't want to do a conversation with a physical therapist. Like, what is he going to say? He's going to say, move your arm, but but it was actually when he talked about holistic physical therapy, I'm like, wait, what? He talked about one story where there's a female that had a hip problem, and he was saying the insurance just wanted to send her to his physical therapy, and he thinks the insurance is just it's like a money, it's a they just looking at her as money, so they just want to send her in, get the physical therapy money, get her out as cheap as possible, and have her continue paying. They don't care about fixing the root of the problem. So he started asking her questions about her habits, why she was having this hip pain, and he found out she was doing, I don't remember how many hours per day, but she was gaming at home. She was sitting at home on a computer or on a console game and just playing video games all day long. So he suggested to her, hey, I think your hip, I forget exactly what the hip problem was, but he said, I think maybe if you cut down the amount of video games and go for more walks, I think that'll help your hip a lot. And lo and behold, that was it.
Wow.
Yeah. So for him, like when I before the interview, I was like, oh, physical therapy, come on. But then afterwards, I was like, oh, this is awesome. These stories of people being passionate about their careers and going above and beyond to help others or to help their environment, to make their environment better. These conversations are amazing. So
Yeah, for
the
sure.
two people that you mentioned, it sounds like they would fit that type of category.
Yeah,
Um,
they've been just fantastic. I think they're good examples. So,
awesome. Last question. Tell me in a few sentences or less what this conversation was like. If you've done a podcast or interview before, describe the biggest difference. I may use this answer in a video collage for new potential guests.
awesome. Yeah, I think this has really been, like you say, just a really informal conversation. I've enjoyed every bit of it because um, I've been able to just kind of freely talk about things that normally I wouldn't open up about, you know. And I mean, obviously, well, I think most of the time I'm at the other side just listening to different podcasts because that's what I love to do. I love to listen to
Me
podcasts.
too.
So I get to actually be a part of it and start talking about the show notes and all, you know, like they always say, oh, I'm going to add that to the show notes. And, all. And so this has been just really a laid back, great opportunity. This is something I've been looking forward to since last week
Oh,
because it's
awesome.
something different that I haven't really done. And it's one of those things where I think probably a year ago before the pandemic, I would have been dreading and probably really fearful of doing because I don't know if I would, you know, thinking, oh man, what am I going to say for 3 hours? I don't know what to talk about. You know, how am I going to respond to these questions and make it meaningful? You know, how is somebody going to want to listen to me? But at least, you know, that has improved a little bit. So I get to see how much we're learning, how much we're growing, how much we're uh, able to make a contribution to other people. So, and I think that's what this is about too, right? That's what it
Exactly.
seems like to me.
Yeah, I think the
Yeah.
stories, whether small or big, um, I had one conversation with a friend that she's a financial uh, what fintech. It was a fintech company, and she was the manager of the customer service. And her story was she's never found a career that she just loves. So she just bounced around for a long time, and I think she's in her 40s now. And the story to me was you don't have to find a passionate career, but find passion in yourself and find a path for yourself. That was kind of what I took out of her story. And to her, I mean, she's like saying, why do you want to talk to me for 3 hours? But I'm really glad I talked to her. So I think yours is, I feel larger dealing with COVID hands on. I, I feel like I couldn't handle the anxiety of March last year if I was in your shoes. Maybe it's different. I guess maybe it's different when I'm talking about I'm a software engineer. When I think about Facebook, Twitter, people talk about your cell phone, if government's taking data from your cell phone. I think my perspective on knowing data, yeah, they could probably take your data, but what are they going to do with it that's detrimental to my life? If we are more, if we're able to look at ourselves and understand what we want, what makes us happy, and what's better for the world around us, I think that's fine enough. If the government's spying, it's hopefully more for like a national security level, not that they're spying because they want to know what pictures I send to somebody or what text message I send to somebody. I don't think that's their goal. So
I agree. Yeah, all
yeah.
those conspiracy theories. I hear about it every day, all day long, about all these theories that are out there. I mean, I just think we have to keep it to the basics, you know. Keep it simple, because if we try to complicate things like that, oh man, we're going to make our lives so anxiety provoked, you know, even more so than it was in March of last year for a lot of us.
Yeah. Dr. Dazley, it was a pleasure talking to you. Thank you so much for your time. I hope we could do this again in person maybe sometime. This was a great conversation, and you opened my eyes on some of the thoughts I had about COVID, the vaccine. Gosh, so many things. But thank you so much for your time.
And thank you for giving me the opportunity to talk to you. It's been an absolute pleasure for me as well. You're great at interviewing and making this such an informal and just laid back thing. Thank you so much.
Thank you so much. See ya.
See ya.